Hello, my dear friends. Hope you all are fine, and I hope that all of you are preparing very much well for your upcoming FMGE exam, beta. And you will be doing wonders. You don't know it yet, but you will be doing wonders on that exam day of 17 January 2026. That is the day for all of you, beta. And I sincerely, from the core of my heart, I'm praying for all of you, each and every one of you, that you come out with flying colors once the exam is conducted and the results are out. Yes, so let us just give them 1-2 minutes time in case anyone wants to join up to see the live session. I hope all of you are able to hear me loud and clear. Yes, good evening, beta. Good evening, good evening, good evening. Yes, Baba re Baba, Biochem. We have not thought of studying this subject, but finally you have ended up studying the subject. And I believe that all of you would have done best to solve even the clinical type questions that will be coming on the exam, even from the subject of biochemistry. Yes, it is quite hard subject initially, but the way we had discussed during the classes, I strongly feel that now this is the cupcake for all of you, and biochemistry is one of the strong points for our paper 1 as well. Yes, थैंक यू सो मच. अभी ठीक करके दे देंगे बेटा, कोई प्रॉब्लम नहीं है. सो यस yes, thank you so much. Thank you so much. Yes, thank you so much, beta. Okay, so without wasting much time, let us try to go ahead with the MCQ session. We shall be discussing about the 25 most important clinical type questions that might be coming from the biochemistry as well. Yes, this session is important. Without wasting time, yes, already 6:05, 6:04. Let us start now with the first question, beta. Let us start now with the first question. Yes, first try to read the question. Don't jump into any conclusion. Take time. This is not a race. आराम से देखो. Try to think about the question and then answer. हाँ, एग्जाम में एकदम पानी निकाल देंगे, पूरा बायोकेम का पानी निकाल के आएंगे. बिल्कुल सही, सही जवाब. ओके, फर्स्ट क्वेश्चन आराम से. नो नीड टू रश. टेक योर टाइम. Okay, the answers are coming now. Yes, beta ji. Yes, all of you are thinking in the right line. Yes, the answer will be D. Exactly, my dear friends. Our favorite answer from biochemistry, as discussed in the classes, it is D. कुछ भी नहीं हुआ तो D लगा के आना है. बिल्कुल सही. The answer of this question indeed is D, beta ji. This is actually a question of galactosemia. Yes, let us try to see the positive findings for everyone. Let us try to see the positive findings, beta, for everyone. Please try to quickly see, make a note of this, beta ji. Please try to quickly make a note of this, beta. Yes, the answer of this question will be D. First, let me mark the right answer over here. This is galactosemia. Now, first thing first, that we have to look for the positive findings. Yes, okay, 4 days neonate, quite early presentation. Lethargic, refusing breastfeeding, vomits during forced breastfeeding, surprisingly accepts glucose water mixture. Okay, accept glucose water mixture. Accompanying mother has reported the same history. Diarrhea on the third day, not from the first day. Usually we have been discussing that in case of primary lactose intolerance, if it is a case of primary lactose intolerance, diarrhea mostly will be notified on the day 1 itself, because it is an inherited deficiency of the lactase enzyme. So primary lactose intolerance cases, we have been seeing that diarrhea usually reports on the day 1, but here the diarrhea reports little late, diarrhea on the third day. Clinical examination, infant pot belly. Yes, pot belly word during our discussion we have mainly talked about in 2 cases. One is the Wernicke disease, second one is the galactosemia. Now we have to rule out between both of them. See, in this case they have also given you an interesting data that there is a chance of E. coli sepsis. Yes, E. coli sepsis, meta. Please remember, E. coli sepsis, Escherichia coli, they basically do survive in our blood with the help of galactose. Galactose is the food for E. coli. That's why they try to invade these neonates who are suffering from galactosemia, because whenever the mother is breastfeeding, the lactose will be breaking them into glucose and galactose. Glucose will be picked up by the cells for glycolysis, but galactose will not be picked up by the liver much, because there is a problem of the liver due to the deficiency of the enzyme either galactokinase or galliput, that is galactose 1-phosphatidyl transferase. In that case, what will happen? Due to the failure of the pathway, there will be excess galactose moving away from the liver, and they will be present in the blood, and in the blood these will work as a food for E. coli. And these are the cases of galactosemia where we are forced to also add antibiotic along with the conventional therapy of galactose free diet, infant feeds that we have discussed. Breastfeeding to stop karna hi hai. In these cases also breastfeeding also has to be stopped, but in this case the diagnosis will be with the galactosemia itself. Yes, it is not primary or secondary lactose intolerance. In case of primary and secondary lactose intolerance, we have been discussing that onset of diarrhea is also very much important. Diarrhea causing the intolerance, it will mainly go for secondary type, but intolerance causing diarrhea, mainly it will go for the primary lactose intolerance type. Here the answer will be galactosemia. All of you know in galactosemia we also have other important clinical features. They might give you an image of the oil drop cataract. They might also tell you about the refusal to suck breastfeed but accept glucose water. They have mentioned about pot belly. And another important thing that we have been discussing during the classes at Miss Beta, very important, that has not been given in this particular MCQ, but please do remember, patients of classical galactosemia, they are also prone to have unconjugated hyperbilirubinemia beta. Jaundice dikhega. In cases of galactose intolerance, that is galactosemia, there will be jaundice if it is a case of primary or classical galactosemia. Please remember beta. So unconjugated hyperbilirubinemia is an added feature by which we can differentiate between von Gieck and galactosemia. Usually we differentiate by that, but in this question the master stroke that we have to remember is the E. coli sepsis. Please remember, almost similar type of history might be given for the von Gieck disease as well. Von Gieck disease patient, pot belly is possible, glucose water mixture they can take, no problem. Diarrhea usually is not seen in case of von Gieck disease. That is another important differentiating feature. And E. coli sepsis is never ever seen in case of von Gieck disease, which is seen mainly, my dear friends, in case of galactosemia. So E. coli sepsis is an important hint over here. Please do make a note of this beta. Oil drop cataract भी दे सकते हैं. Please remember, day 1 diarrhea most commonly primary lactose intolerance, because it is an inherited deficiency, and diarrhea will be notified. Although mother will ignore that, he will be coming to us little late. Problem starts in case of primary lactose intolerance early, but the presentation of the child to the OPD or to the emergency room will be little late. But in case of galactosemia, the mother will be forced to bring her child much more early, because here there is a refusal to suck breastfeeding mainly. That is the major challenge over here, right? Thank you so much. And urine RE reveals the presence of the reducing sugar in the urine, and all of you know, for this test they might also ask you, for the reducing sugar test we might go for something called as the Benedict test. We can go for something called as the Benedict test. Benedict test karenge and you will be able to see that the color changes will be seen. Glucose, fructose, galactose, maltose, lactose, all are reducing type of sugar. So the Benedict test also will be coming positive. Along with E. coli sepsis, they might also add over here this thing. Please remember, Benedict test usually is not needed in case of von Gieck disease as well. This is another added feature that is positive for the galactosemia, right? Moving to the next question. Yes, von Gieck disease, there is a massive severe hypoglycemia. Severe hypoglycemia, very good. But von Gieck disease में there is a fasting hypoglycemia in between feeds, that is not so much seen in case of galactosemia. Yes, coming to the second question, beta. Thank you so much. Yes, that means you have all been studying. Yes. Yes, beta ji, I hope all of you are able to see the question loud and clear. आराम से, no need to panic, take time, no need to rush, time है, no need to rush. Look for the positive findings, beta. Few of you are answering it as C, few of you are answering it as B. C, yes, my dear friends, all of you are mainly thinking in the right line. The correct answer for this question will be C, beta. Yes, all of you are right, beta. Please remember this. Correct answer for this is going to be C. All of you are right. Big thumbs up for all of you, beta. Yes, C is the right answer. C is the right answer. Okay, let us try to approach this question. Let us learn something new. 42-year-old female, okay, 42-year-old female at the age around 40 year. First of all of you know rule of 4F that you have studied in surgery as well as you have also studied in case of biochemistry. Rule of 4F, female, fertile, fatty, 40 is the age group where the chances of the gallbladder stones are actually quite more. So the age of the patient itself is hinting us towards this. So please do keep it in mind. Yes, healthcare clinic, जनरलाइज्ड वीकनेस है, ओके ठीक है, इचिंग है, इचिंग जॉन्डिस, इक्टेरस, जॉन्डिस, इचिंग, okay, single episode of vomiting, yellowish discoloration of the sclera, so it is case of jaundice. She was otherwise fine. Total bilirubin 5.6, not so much elevated, but the conjugated one is more elevated than the unconjugated. Told you, rule of thumb as per Harrison's textbook of medicine, if it is a case of obstructive jaundice or post-hepatic jaundice, which is also called as surgical jaundice, please do keep it in mind, conjugated bilirubin will be minimum more than half of the total bilirubin level, and in this case it is clearly matching that the conjugated bilirubin is more, so that means the problem is after the liver, outside the liver, my dear friends. ALP is elevated. Yes, ALP do elevate in case of obstructive jaundice cases. AST is mild to moderately elevated. AST is up to 40-45, it is normal. ALT is also little bit elevated, but there is also a rise of the GGT, gamma glutamyl transferase, and we have studied also in our notes that whenever ALP and GGT are rising together, mostly the answer will go for the obstructive jaundice, beta. And one of the important extra hint that they had given, that is also we have discussed in our classes, urine में bile salt positive है, and this is confirmed by the Hayes sulfur test. I told you a special urine test that is done in case of obstructive jaundice patients. This is the Hayes sulfur test. USG whole abdomen report was not available. Mainly it is a case of rural setup. Now what is the probable diagnosis? Answer will go for the obstructive jaundice, mostly secondary to gallstones. Here they have not talked about any pancreatic problems, otherwise the answer could be also due to carcinoma of head part of pancreas as well. But in this question they have not mentioned any data regarding those pancreatic issues, so we have to rule that out. So this is mainly a case of obstructive jaundice. GGT and ALP together, GGT ALP together, obstructive jaundice is the most common type that we have to remember over here. Hemolytic jaundice cases में बाकी को भी एक बार देख लेते हैं बेटा. Why it is not hemolytic jaundice? Because in case of hemolytic jaundice we mainly see the rise of the unconjugated bilirubin more. RBC का breakdown ज्यादा हो रहा है, right? So in that case, hemolytic jaundice में we will see the UCB rise more than the CB rise. Acute viral hepatitis, this is a case where for a transient period of time inside the liver there is highest infectivity, and due to which the liver enzymes will be shooting up, mainly the ALT, AST will be sky high. Please do remember this, that is also a PYQ from our exam, that if you see some bizarre values, utpatang values, peculiar values of ALT, AST becoming so much high, ALT becoming more than 2000, 3000 international units per liter, AST becoming more than 2000 to 3000 international units per liter, in that cases those bizarre values that we may get, that might point toward acute viral hepatitis. And in case of acute viral hepatitis, usually the ratio of conjugated unconjugated more or less remains same, 50-50 to each other, because it is a problem inside the liver. Remember the catch, if it is a problem before the liver, UCB will be higher than the CB. If it is a problem after the liver, CB, conjugated bilirubin, will be more than the UCB, unconjugated bilirubin. But if it is a problem within the liver, then mostly the ratio of conjugated and unconjugated will be similar to each other. This is how you try to rule it out. Why not Gilbert syndrome? In case of Gilbert syndrome, mainly, my dear friends, you don't get to see these things positive at all. It is a lifelong disease, my dear friends, but it is a milder variety. There is no cure, there is no treatment which is also required, and we have got normal liver enzymes. Please do remember, in case of Gilbert syndrome, my dear friends, we usually do not see elevation of these enzymes that we have been discussing it over here. Please remember, Gilbert syndrome में, let me write it one important point over here. Usually we have normal liver enzymes, beta. Usually we have normal liver enzymes. This is a very, very important point that we have to also remember over here, beta ji. Obstructive jaundice, that is an important point. Here phenobarbital is not much effective, beta, because phenobarbital is an enzyme inducer that induces UGT enzyme, UDP, glucuronide transferase, and that is an enzyme which is required for the conjugation of unconjugated bilirubin to conjugated bilirubin. Here in the case of obstructive jaundice secondary to gallbladder stone, there is no problem in the conjugation, there is nothing wrong in the liver, so there is no role of phenobarbital over here. यहाँ पर देने का कोई फायदा नहीं है. Here this type of obstructive jaundice is also called as surgical jaundice, because the only way we can treat these cases are by surgeries. You have to call her, plan a date, take her, remove her gallbladder and send her back. That is the way forward that we can remember, that most of the cases it is isolated and it is treated by the surgeries. We have to remove the obstruction, beta. Phenobarbital is mainly important for the our conjugating problem, beta. Cholecystectomy we have to go for. Yes, any other thing? Cholecystectomy. Okay, so let us write down some important features, beta. Let us also learn, like all of you have agreed. I am writing one more time. ALP rising together and GGT also rising together. Most of the time it is going to be a case of obstructive jaundice. Mostly it is going to be a case of beta obstructive jaundice. Please remember, ALT rising too much, AST also equally rising too much, then I told you this is a case of acute viral hepatitis. It is going to be a case of beta acute viral hepatitis. Please remember, AST rising too much, GGT also rising too much. AST and GGT both are rising too much. In this case, we have to think about mainly problem of cardiac origin, beta. Cardiac origin. And most of the time in the patients of myocardial infarction, we also do get to see this. Although these are not the markers that we usually do in case of MI patients, but in the MCQs they had been using this terms that AST, GGT together they will be rising in case of what? It is going to be a cardiac origin. Please remember, in these cases, if isolated ALP rise too much, कि पेशेंट में सिर्फ और सिर्फ अल्कालाइन फॉस्फेटेस का ही राइज हो रहा है, अदर markers of the liver enzymes are not rising much, then it is not a problem related to the liver at all, beta. We have to think about bone origin. Isolated rise of the ALP, my dear friends, we have to think about bone origin. Remember, there might be some also cases like this. Please remember, I am writing alcoholic liver disease. In alcoholic liver disease, my dear friends, please try to understand, we have different type of markers which are also equally important. In case of alcoholic liver disease, please quickly make a note of, if you are noting it down, please remember AST ALT ratio, AST ALT ratio, which is also called as D-Ritis ratio. If it is more than 2, AST भी rise हो रहा है, ALT is also rising together. Both of them are rising together. Please remember, Like we have studied that ALP, AST mainly rising together, it can be going for viral hepatitis. But if the rise of AST is twice the value of rise of ALT, then my dear friends, we have to talk about alcoholic hepatitis. This is mainly going to be for alcoholic origin beta. This is going to be alcoholic hepatitis over here beta ji. And in case of alcoholic hepatitis, AST ALT ratio is rising more than 2 is the most specific test as well, most specific test. However, for alcoholic liver disease, you can also go for another parameter rise, that GGT rise. GGT rise is also significant, but in this case, this is mainly due to heavy alcohol intake. This is mainly, my dear friends, due to heavy alcohol intake. Heavy alcohol intake agar hoga, see, the patient might be chronic alcoholic, but mildly chronic alcoholic. He drinks only limited amount, 30 ml. For them, GGT rise might not be that much significant. If you want to see GGT rise in a alcoholic liver disease patient, you have to understand that the patient must be drinking quite a load of alcohol on a daily basis. 30 ml के जगह पर वो 60 ml 90 ml तक जा रहा है daily basis में. Then only the GGT rise will be much more significant. But in most of the cases of the alcoholic hepatitis, whether the cause of the hepatitis is due to alcohol or not, that you can rule it out by this answer: AST ALT ratio, that is also called as D-Ritis ratio, that is more than 2, where AST rises twice the value of the ALT value or more than that. Please remember. Chronic alcoholic. And nowadays we have also been discussing during the classes. I told you there is a new marker in the market. All of you know, not that much new. It is there since long time, but it came to the limelight very recently. This is called as the carbohydrate deficient transferrin. Yes, carbohydrate deficient transferrin, my dear friends, this is also true for the heavy alcoholic intake as well. But we have also been writing another important point, that it is binge drinking. And in this case, CDT rise will be mainly possible if the person is consuming more than 60 gram per day, not 60 ml per day. Remember, my dear friends, we have discussed this during the classes. If you want to see CDT rise in a patient, then the patient must be consuming more than 60 gram per day of alcohol. It will depend on what sort of alcohol he is drinking. Please remember, beer पी रहा है कि rum पी रहा है कि whiskey पी रहा है कि कुछ दूसरा खुद बना के पी रहा है. Please try to understand, my dear friends. This is how you try to rule out the question. Alcoholic liver disease is often confusing. Most specific test, if they ask you, AST ALT ratio more than 2. Heavy alcohol intake, GGT rise. Binge drinking, heavy alcohol value, they have been mentioned 60 gram per day. And CDT, all of you know, is also correlated in ENT for the CSF rhinorrhea thing. All of you know, I'm not going into that, sticking to this. So this is one important data that we need to remember better. This is, you try to rule it out. Unconjugated bilirubin. Okay, few of you are asking me about pre-hepatic, post-hepatic. Writing quickly in short, please make a note of this. UCB will be more than 80% of the total bilirubin, and conjugated bilirubin, my dear friends, conjugated bilirubin will be less than or equal to only 20%. If it is a case of pre-hepatic jaundice, hemolytic jaundice, pre-hepatic, UCB rise will be more than 80% of the total bilirubin, and conjugated bilirubin will be 20% or lower than that. If it is a case of hepatic, UCB will almost equal to conjugated bilirubin, that is 50% each. This 50% each, more or less, hepatic origin, UCB will be almost clear to CV. And in case of post-hepatic, conjugated bilirubin has to be more than 50%. Conjugated bilirubin has to be more than 50%. Yes. Yes, CDT beta is also called as beta-2 transferrin that we have been discussing during the classes. Thank you so much. Yes, these are some interesting data that we need to remember on the exam day to rule it out, right? I hope in case you are making notes, you are able to note it down. Yeah. Thank you so much. So in this question, female gender, everything is matching over here. His sulfur test positive, gallstones. Quickly, let us see the question, beta. Yeah, I am here. Don't worry. I'm just not keeping little well. That's why taking some hot sips of water. That's it. Okay, beta. Question. Question क्या था? Okay. क्या था ये? मैंने तो देखा ही नहीं. हाँ. On the exam day. Hello, 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 hello. On the exam day, only thing that is keeping you away from your success is your silly mistake and not reading the question properly. My dear friends, please read the question carefully, read the question carefully, read the question carefully. That is the only thing lying between you and your success. What is the question they have asked? Are Baba Re, Baba Re. Mm, 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 mm. Now the answers are coming. Yes, my dear friends, question को पढ़ो. अभी अभी सीखा. Right now we have learned. Apply that. See in this question, what is this question? It is a case of MI. It is plain and simple is a case of MI. What type of MI? They have also mentioned that it is a case of inferior wall MI. ये 45-year-old male, emergency department, pain radiating to left shoulder, MI, 12 bleed ECG, लॉन्ग लीड 2 भी लिया है तो समझने के लिए लीड 2, 3 एंड AVF. MI का डायग्नोसिस CCU में शिफ्ट हुआ, LFT भी भेज दिया because whenever any critical ill patient is there, you are shifting the patient to the ICU. As a simple general medicine doctor, you will definitely go for the multiple other tests as well. And LFT was also eventually done for this patient. क्वेश्चन क्या पूछा है? LFT के जो 4 एंजाइम्स होते हैं उसमें से कौन से का राइज नहीं होगा? Which rise will not be seen? Please try to understand. I just now told you it is ALP, alkaline phosphatase, my dear friend, is the right answer over here. Alkaline phosphatase least likely to be elevated because in our previous discussion, my dear friends, please remember we have been seeing ALT can rise, AST can rise, GGT can also rise in the patients of MI, but only liver enzyme that is never ever elevated in the patients of myocardial infarction disease, this alkaline phosphatase. Please remember, least likely. Yes, ALP isolated rise, just now we have studied, we have to mainly think about bone origin. Red color में अभी अभी लिखा था isolated ALP rise, bone origin. It might be a case of osteosarcoma, osteoblastoma. In orthopedics you must have heard about Perthes disease. Perthes disease में भी ALP का लेवल काफी बढ़ जाता है. Paget's disease, you must have heard about Paget's disease. Paget's disease, Perthes disease में alkaline phosphatase level is more. Simple thing, osteomalacia, rickets, ALP level also will be sky high. बट बाकी के जो एंजाइम्स होते हैं वो कभी नहीं बढ़ेंगे. रिमेनिंग थिंग्स विल नेवर एवर राइज ओवर हियर बेटा. सो आइसोलेटेड ALP राइज, वी हैव टू थिंक अबाउट द बोन ओरिजिन. बोन ओरिजिन, प्लीज डू रिमेंबर दिस बेटा, वेरी वेरी इंपॉर्टेंट. एंड दिस ALP इज नॉट फाउंड इन आवर हार्ट एट ऑल. 1% भी ALP हमारे हार्ट में नहीं है. There is not even a single percent ALP found in our heart. That's why ALP is the enzyme that is never ever elevated in the patients of myocardial infarction. Please remember, least likely. Yes, thank you so much. Least likely. Okay, I told you this question is important. आराम से Big thumbs up to all of you. Big thumbs up to all of you, beta. The correct answer of this question indeed is reduced form of glutathione. We have been discussing this question multiple times during the classes, during our subject wise test. I thought of giving the same thing to boost your momentum even for the 25 most important YouTube session. Similar type of story that came also in our real life exam. Young traveler, India, northern state, planning for southern state of India. These are the words we have been saying in the classes. Malady is endemic. High dose of chloroquine. Oh my god. High dose, self prescription, dangerous thing. Please remember, high dose of chloroquine as a precautionary measure. And malaria हुआ तक नहीं, पहले से ही दवाई खाना स्टार्ट कर दिया, वो भी high dosage of chloroquine, and unfortunately immediately lands with an attack of hemolytic anemia. And what is the most common cause of hemolysis? Reduced form of glutathione. Let us remember the pathway one more time, quickly showing you the pathway. Try to follow it over here, beta. We have been seeing that in the topic of our HMP shunt, hexose monophosphate shunt, we have studied that G6PD. What was the name of the enzyme, beta? What was the name of the enzyme? G6PD. Glucose 6-phosphate dehydrogenase is the enzyme that is capable of producing this Brahmastra compound that is known as NADPH plus H plus, which is further capable of changing the GSSG form to GSH form. This in our note we wrote it like this: GSH HSG. Please try to make a quick note about this, but try to focus over here. From the NADPH plus H plus, 2 hydrogen is added in this structure. This is the structure for the oxidized glutathione, where the hydrogen is added. These 2 hydrogen from the NADPH plus H plus came and joined over here, GSH HSG. And my dear friend, name of the enzyme was called as glutathione reductase, which is FAD dependent. And this GSH HSG further, which is called as reduced version of glutathione, reduced glutathione, because it is added with hydrogen, so it is called as reduced glutathione. This is capable of also adding the same 2 hydrogen with the H2O2. So if you just write this H2O2 plus 2 more hydrogen from this structure, because 2 hydrogen from this guy is given to this guy, so H2O2 plus 2 hydrogen might be converted to this molecule, 2 molecules of water. This is how the toxic, dangerous hydrogen peroxide, which might be building up in our RBCs inside in the cytosol as we speak right now, this will be immediately getting converted back to 2 molecules of water, which is a quite safer compound. This is another reason that there is a continuous production of the water molecule inside the RBCs itself. RBC के अंदर पानी आया कहाँ से? Please try to understand this. RBC are continuously producing water, and the second enzyme name is called as beta glutathione peroxidase, which is dependent on the selenium. Now in this, what is the job of chloroquine? Chloroquine, my dear friends, is capable of inhibiting this first enzyme that is called as glutathione reductase. The guy, chloroquine and some drugs, they are capable of inhibiting this glutathione reductase enzyme. That's why this conversion will be stopped, and this life-saving compound that is known as reduced form of glutathione, it will not be made. And that's the reason whenever there is a production of H2O2 in the RBCs, it will not be broken down safely to water. This guy can build up, which can further lead to free radical synthesis, and it will cause the rupture of the RBC membrane, finally causing hemolysis, right? Please try to remember this. This is an important point. Try to understand. And also there is a correlation of this with Plasmodium falciparum. I told you that in a patient of pre-existing G6PD deficiency, they are somehow protected from Plasmodium falciparum malaria, because if a person is already suffering from G6PD deficiency, patient को पहले से G6PD deficiency था, in those patients, what is the problem? If you are G6PD deficient, then NADPH plus H plus production also will be less. And this guy, life-saving guy, purple color guy over here, reduced glutathione production also will be less. And this is the guy that is the food for Plasmodium falciparum beta. Plasmodium falciparum is able to survive within our RBCs by eating this guy. If you are G6PD deficient, this guy will not be made inside your RBC, and you will not be able to manage That's the reason Plasmodium falciparum do not like to invade those people who are already suffering from GCSPD deficiency, because in them, in their RBC, their food is missing. That's the reason, my dear friends. Please do remember this. Some extra knowledge that might help you on the exam day. We have discussed only limited number of drugs during our classes. We have also talked about sulfa group of drugs, mefenamic acid as an antipyretic medication as well. But we should remember the other drugs as well. Coming to the list of the antimalarial drugs, we should avoid primaquine, pamaquine, quinine, chloroquine at higher doses. Question में यही दिया हुआ था, high doses of chloroquine, that should be avoided. What are the antibiotics? Mainly sulfa drugs. In our notes, we have already discussed sulfamethoxazole. I told you it is mainly given in case of urinary bladder infection. We can also give it along with trimethoprim. Nitrofurantoin, my dear friends, a very commonly used drug which is given in the case of UTI, urinary tract infection. डॉक्टर लोग छप्पड़ फाड़ के ये नाइट्रोफ्यूरेंटाइन मार्केट में देते हैं. प्लीज रिमेंबर दैट इज ऑल्सो ए पोटेंशियल थ्रेट for GCSPD deficiency patients. Dapsone, oh my god, all of you know about this. Nalidixic acid and ciprofloxacin. List is big. Please try to understand. And analgesic antipyretics, aspirin, phenazopyridine, and acetanilide. Acetanilide also can cause this. Some other medications, methylene blue. All of you know during your gout treatment, you must have heard about something called as rasburicase, newer generation drug, but it is a potential threat that can also inhibit the reduced glutathione synthesis by blocking the glutathione reductase enzyme. Toluidine blue hai, isodiazolidine hai, and vitamin K in large doses. Usually that is not seen in India. Large dose of vitamin K we should avoid. But another question that came in the past, I want to highlight over here. What are the other triggers? ये तो drug का बात हुआ. Drugs we have discussed, but please remember other food item, fava bean. Fava beans, my dear friends, also came as a question in our exam earlier. Fava beans, broad beans, kidney beans, they are also a potential threat for GCSPD deficiency patients. And please remember naphthalene balls. Oh babare baba, naphthalene balls or the moth balls, they are also important for our exam beta. Please do remember these two additional points as well. It is not only drugs, but also fava beans and naphthalene balls, my dear friends, are also important. Viral bacterial infection में तो overall production of the liver pathways will go down. That is a simple logic that we can remember better, right? So ये कुछ additions मैंने किए हैं during the 25 most important session. Please make a note of this. इतना सारा drug तो याद नहीं रहेगा, जितना भी याद रह जाए, please remember. But these are the commonly used drug, and do remember these two guys, fava beans and naphthalene balls, dangerous. Please try to remember this. Other triggers. Okay. All related to GCSPD deficiency anemia. वो जो thing, all the list, yes, they can be a threat for GCSPD deficiency patients. Yes. Big thumbs up to all of you beta for getting this question correct. Great job, great job, great job. 5-hydroxyindole acetic acid. This is the guy which is also called as 5-HIAA. 5 here is the name. Some people also call it as only HIAA. Please remember 5-hydroxyindole acetic acid. See the question. 42-year-old lady, school teacher, endocrine OPD, flushing. Okay, what flushing of the face? Signs of pulmonary edema and pellagra-like ashes. Pellagra-like rashes. Pellagra-like rashes, my dear friends. I told you, pellagra-like rashes may mainly we should not think about vitamin B3 deficiency directly from the nutritional point of view. If the word like is given, we have to think about other causes. And all of you know here extra additional information has been given. non-malignant ovarian teratoma with argentophin cells in large number. So it is a clear-cut case of argentophenoma. Normally, we have studied argentophenoma, my dear friends, is coming from where? I told you the mnemonic is like this: era. What is the mnemonic era? Ileum rectum appendix. As per Harrison, ileum rectum appendix. But here, I also wrote in the notes that there can be some other peculiar sites like ovarian teratoma, non-malignant ovarian teratoma with argentophin cells, because argentophenoma mainly initially starts as a benign tumor only as a localized tumor. After the surgery was done, all the symptoms had disappeared except the cardiac. My dear friends, I am asking you a question, not from this, extra question. Why the hell cardiac symptoms did not disappear? ये कार्सिनोइड सिंड्रोम का केस है, एवरीबॉडी कैन आंसर स्टैंड. द डायग्नोसिस ओवर हियर इज प्लेन सिंपल एज MCS. MCS full form is malignant carcinoid syndrome. Okay, diagnosis is done. I am asking the cause. सारा कुछ ठीक हो गया, हार्ट का प्रॉब्लम ठीक क्यों नहीं हुआ? आंसर. Why the hell except the cardiac? What is the reason? देखते हैं कितना याद है. Except the cardiac. Why? Yes. Why except cardiac? एक्स्ट्रा पॉइंट ऐड किया है. एक्सेप्ट द कार्डियक. यस, ट्राइकास्पिड वाल्व स्टेनोसिस. माय डियर फ्रेंड्स, वेरी 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 इंपॉर्टेंट आंसर. TVS, tricuspid valve stenosis. We have been discussing about this during the classes, that whenever we have massive serotonin overflow, ultimately it will be also circulating within the heart chambers, mainly the right side of the heart, because serotonin, after coming away from the liver, portal vein draining into inferior vena cava draining into right atrium draining it into right ventricle. Between right atrium and ventricle we have a watchdog that is called as tricuspid valve, and if serotonin spends longer time inside those chambers, it will lead to tricuspid valve stenosis. That is the reason patient of argentophenoma, if it is a complicated case, if it is a long-standing case, it will also come to you with right-sided heart failure. And that's why, although the surgery had been done, but they had not performed any valvular surgeries or valve replacement at all. So that's why cardiac symptoms did not disappear. Maybe they have to call the patient again sometime later for that heart surgery to be performed later as well. And they have asked, excretion of one of the metabolite comes back to normal, which was initially elevated. That is the answer, 5-hydroxyindolacetic acid, because serotonin, my dear friends, serotonin, if it is increased, either it can lead to tricuspid valve stenosis, and it can also be degraded to 5-hydroxyindolacetic acid. And we have studied that the name of this enzyme is called as MAO. Name of the MAO is monoamine oxidase. So excessive dosage of MAO inhibitors can also give you happiness, but the problem is too much happiness sometimes can be dangerous, because too much happiness can also cause tricuspid valve stenosis. जोक्स अपार्ट, ज्यादा खुश होने का भी जरूरत नहीं है, ज्यादा दुखी होने की भी जरूरत नहीं है. जैसे चलना है चलने दो. The show must go on. Please remember, my dear friends, serotonin to MAO will be overperforming over here, because it is a case of argentophenoma. Right. Hope all of you are able to remember this. Tricuspid valve stenosis, right-sided heart failure. Remember, serotonin overload never ever causes left-sided heart problem. It always causes right-sided heart problem only, because it never ever enters to the left chambers, because it is totally broken down by MAO. 60% in the liver, 40% in the lungs. ठीक है, बाकी लंग्स में जाके मेटाबोलाइज हो जाएगा, एंड इट विल बी गोइंग टू द सिस्टमिक सर्कुलेशन एज 5-HIAA. 5-HIAA is a non-toxic guy. Oh, 5-HIAA is a non-toxic guy, but serotonin, my dear friends, if it is high, it is toxic. Please remember, 5-HIAA से बिल्कुल डरना नहीं है. वो निकल रहा है, उसको निकलने दो आराम से, कोई प्रॉब्लम नहीं है. But serotonin becoming high is the challenge. Please remember, this was the pathway that we have been discussing, that in this serotonin, my dear friends, once it is formed, it will be broken down to 5-hydroxyindolacetic acid. Name of the third enzyme of this pathway is MAO. What is MAO? Third enzyme name is written over here, beta, monoamine oxidase. We have been discussing just now. Quick recap. Most common site as per Harrison, ileum rectum appendix. Diagnosis, serotonin. 5-HIAA will be also increased, but in the urine. Neuroendocrine marker, I spoke during the lectures, but I did not write it on the note. In case anyone is interested, you might add it on in your notes. But I told you the gold standard is this. In India, the gold standard is urinary marker. But अगर patient के पास ज़्यादा पैसा है, then they can also opt for some special highly costly type of tumor markers over here. I talked about chromogranin A, I talked about neuron specific venolase, and another one is beta synaptophysin. Extremely costly test. People usually do not vote for this. 5-HIAA is quite similar along with the clinical diagnosis. Clinical symptoms, mainly we have talked about this intermittent diarrhea, flushing of the face. Flushing of the face is also quite common over here. Sweating will be there. Diaphoresis, not hyperhidrosis. You don't see hyperhidrosis in this patient. That is different. This is diaphoresis, fluctuating hypertension, and the last one, pellagra-like symptoms. Please do remember about this. प्लीज रिमेंबर. ओके, जोक सपाट, ठीक है. आगे बढ़ते हैं. सम मोटिवेशन हो जाए, इतने दिन से बात कर रहे हैं. माय डियर फ्रेंड्स, टू बी ऑनेस्ट विथ यू, इट हैज बीन एक्चुअली अ लॉन्ग जर्नी फॉर ऑल ऑफ यू. द जर्नी ऑलमोस्ट बिगन 5-6 years back. Lots of ups and downs have come in your life and gone. If you would have been got a chance to do medicine in India, then things would have been much more easier, isn't it? Sometimes if it is in your own city, you would have been staying at your own home, you could have been a day scholar, you would have got home food. बहुत कुछ मिल सकता था जो हमें नहीं मिला. हमें बहुत सारी चीजों से वंचित रखा गया है. But nothing to panic बेटा. Whatever happens happens for a reason. Whatever has been gone, you cannot remorse on that. ऐसा होता तो ऐसा होता, बहुत कुछ होता. जो भी हुआ है अच्छे के लिए हुआ है. टेंशन उतना लेने का बात नहीं है. You have already done the hard part, surviving in a country for 5 long years in those tough terrains as well as in those tough cold climates. I know the students from Russia, that how difficult it has been for them to survive in those extreme cold temperature, and I have seen the devotion after going there as well. So from the bottom of my heart, a big thumbs up for all of you who have come across to all those hardships in your life, and finally you are at this juncture of making history for yourself. You are so close to the victory beta, and ये कुछ लास्ट के कुछ दिन बाकी है बस. Somehow you have to give your best so that the last checkpoint that you are there, last checkpoint है बेटा. पहले के सारे चेक पॉइंट को आप क्रॉस कर लियो, ऑल द चेक पॉइंट्स आर डन, ये लास्ट वाला बस एक चेक पॉइंट है. एंड somehow my dear friends, you need to just cross that check point. एक बस गेट कीपर खड़ा है. गेट कीपर का नाम है FMGE. जाना है, उसको मुक्का मारना है और कुछ नहीं करना है. देखना बेकना कुछ नहीं है, पूरा पेल देना है, सामूहिक तरीके से पेल देना है. जाना है, पेलना है, दरवाजा तोड़ के आगे बढ़ के घुस जाना है. दैट इज द ओनली थिंग व्हिच इज लेफ्ट आउट बेटा. Sincerely praying for my dear friends, all of you, that you come out with flying colors when the exams are done, because you are already done the hard part. You are very close to the victory, and success, my dear friends, will be definitely yours. Only thing, do not do silly mistakes on the exam day, and success, my dear friends, will be yours. Coming to the 6th question beta. कुछ नहीं, सच बोलने से इतना डरना क्या. क्वेश्चन को देखो, रीड इट केयरफुली, लुक फॉर द पॉजिटिव फाइंडिंग्स एंड आंसर. इजी क्वेश्चन है. Yes, my dear friends, yes, all of you are thinking in the right line. Some easy question. Increased conversion of pyruvate to lactate. Yes beta, increased conversion of pyruvate to lactate. Please remember, vigorous exercise you are supposed to perform in the gym to achieve your target body weight. That's why there will be more chance of anaerobic glycolysis in a high strenuous condition, and pyruvate will be forced to get converted to lactate by the help of enzyme lactate dehydrogenase. However, although this is a chocolate question, easy question, but if I just change the word increased NADH plus H plus ratio to decreased NADH plus H plus ratio, please tell me option number B also will be correct or not. If I just switch one word from increased to decreased NADH to NAD plus ratio, please tell me whether the option number B also will be correct or not. अगर ये डिक्रीज कर दिया तो क्या होगा? Waiting for your answers. Yes, my dear friends. Yes, अगर ये सेकेंड ऑप्शन इंक्रीज से डिक्रीज हो जाता है बेटा, then my dear friends, even this answer also will be correct, because all of us know during that LDH reaction, pyruvate will be converted to lactate. LDH is the enzyme. LDH, lactate dehydrogenase. From lactate side you remove hydrogen, but from pyruvate side you add hydrogen. Pyruvate to lactate, NADH plus H plus will be used and NAD plus will be produced. So gradually the NADH plus H plus reserve in your working muscle also will go down because NAD plus will be increased. So decreased वाला option भी सही होता. And please remember option number 3. Option number 3 में increased concentration of creatine phosphate है. I am just again changing it to decreased. Now option number C also will be correct or not? Option number C also will be correct or not? Increased को change करके decrease कर दिया. Option C, will it be correct or not? Yes, that also will be correct, because all of us know creatine phosphate is the major ATP producing substance in our working muscle that supports for ATP production, ATP regeneration for up to 1 minute. I'm talking about heavy gym. In heavy gym, after 1 minute, their level will be decreased over here. It cannot be increased. Increased to tab hoga when you have ATP produced higher in amount. When you are planning for storing ATP in the creatine phosphate form, then increased concentration of creatine phosphate will be possible. But during the gym, you will be extracting ATP production from creatine phosphate. So creatine phosphate ka level will be becoming less, and my dear friends, the ATP level will be becoming more. So this also will be decreased. And what is the last option over here? Decreased level of fructose 2,6 bisphosphate. What is the fructose 2,6 bisphosphate? All of you know fructose 2,6 bisphosphate is the allosteric activator of PFK1. इसको भी देखते हैं, समझते हैं बेटा. Don't just mug up the answer. Try to understand. Fructose 2,6 bisphosphate is the allosteric activator of the enzyme phosphofructokinase 1 or the PFK1, right? Now, what happens in working muscle? I told you continuous supply of ATP. Up to 1 minute, creatine phosphate. After 1 minute, muscle glycogenolysis. But that also will not be for hours. That will be for few more minutes. After that, normal glycolysis has to happen to produce ATP. That's why in a working muscle, we need to perform the glycolysis further on, and to continue the glycolysis, my dear friends, decrease nahi, yahan par bhi my dear friend, this also has to be increased level of fructose 2,6 bisphosphate. Then my dear friends, all the 4 options would have been the right answer. Please remember, very interesting question, very important point. Try to understand. Fructose 2,6 bisphosphate is an activator of glycolysis, inhibitor of gluconeogenesis. वो ग्लूकोनियोजेनेसिस को इनहिबिट करता है because it blocks the enzyme. We have studied it blocks the enzyme fructose 1,6 bisphosphatase. Fructose 1,6 bisphosphatase. People call it in short as FBPS. FB. People call it as beta FBPS or fructose 1,6 bisphosphatase. That inhibits the gluconeogenesis. So here do keep it in mind, in an high stress situation, high strenuous condition, we need to do increased conversion of pyruvate to lactate, decreased NADH plus to NAD plus ratio, decreased creatine phosphate, and increased fructose 2,6 bisphosphate. And my dear friends, I'm asking you a simple question: what will happen to this lactate? What will happen to this lactate? Hello. What will have to happen to this lactate? Lactate तो बन रहा है, lactate को कैसे handle करोगे? Hello, my dear friends, how will you handle the lactate further? How will you handle the lactate further, बेटा? लैक्टेट को कैसे कंट्रोल करेंगे हम लोग? लैक्टेट बाप रे, इजी कोरी साइकिल, अरे बाप रे बापा कोरी साइकिल. And lactate, my dear friends, will be transported by the guy called as RBC, and RBC will take it to the liver, and in the liver, my dear friends, lactate again will be converted back to glucose finally by the process of gluconeogenesis, and this glucose will be never ever given to glycolysis in the liver. Rather, this glucose will again come back to the skeletal muscle, and in the skeletal muscle it will again go for glycolysis. This is how the complete cycle sums up. Please try to understand better. The lactate will be carried by the RBC to the liver. In the liver, lactate will be going back to a safe compound glucose. Glucose will come back again via the RBC given to the skeletal muscle, and for that we need to promote glycolysis. So the continuous production of ATP can be handled during the heavy exercise. This is the complete physiology, including biochemical aspect together, for the prolonged or strenuous exercise in our working muscles. Thank you. Question number 7. इजी है, ज्यादा मत सोचो, इजी क्वेश्चन है. कहाँ गए? हेलो, वेयर आर यू गाइस? कहाँ गए? सो तो नहीं गए? ए क्वेश्चन ठीक से पढ़ोड़े. ओ माय गॉड. अरे भाई, यू नो द टॉपिक, यू नो द टाइम फ्रेम, रीड द क्वेश्चन प्रॉपरली ना. ये क्या है? ये क्या गलत आंसर क्यों दे रहे हो? वाई आर यू गिविंग रॉन्ग आंसर्स? अरे यार, थोड़ा सा पढ़ो आराम से, नो नीड टू रश. सबसे पहले आंसर करना ऐसा जरूरी नहीं है, आराम से, टेक टाइम. अब जाके आंसर चेंज हुआ. नाउ द आंसर इज चेंजिंग बैक टू बी. वाई? प्लीज रिमेंबर बेटा जी, ऑल ऑफ अस नो, माय डियर फ्रेंड्स, up to 18 hours it is the liver glycogenolysis. It is the liver glycogenolysis that takes care of the glucose level in the blood. More than 18 hour till 72 hour, sorry, more than 18 hour till 72 hour, it is liver gluconeogenesis. We have been discussing about this. क्या क्वेश्चन क्या पूछा है? क्वेश्चन पूछा है wakes up at 7:30 AM for breakfast, finish dinner at 8:30 PM. 8:30 PM से 7:30 AM कितना हुआ? 11 घंटे ही तो हुए. Up to 18 hour it is the glycogenolysis and all which is capable of. Yes, there can be little bit of gluconeogenesis as well. I can understand, थोड़ा बहुत होगा. 10% gluconeogenesis activation is possible in a well-fed state as well. That also we have studied, right? But normally the best possible answer, we have to remember, it is going to be for glycogenolysis. Yes, 18 hours. मोर देन 18 आवर ग्लूकोनियोजेनेसिस इज एज इज फुल पोटेंशियल. हमें ये देखना है कि कब वो मैक्सिमम स्पीड में है. मैक्सिमम स्पीड ऑफ ग्लूकोनियोजेनेसिस इज अचीव्ड ओनली आफ्टर 18 आवर मार्क बेटा. Up to 72 hour he can take care. After that the fats are mainly taking over. Simple question, please do make a note of this. Remember that chart that we have been discussing in our workbook, okay, each time frame till 1 month freedom fighter story that we have been discussing. Please remember, because of whom we are all here. God bless them. Question number 8. Repeat question of your FMGE exam. Repeat question in our subject wise test. Repeat question that you have seen multiple times. If both are given in the same option, you can also mark that both glycogenolysis and gluconeogenesis, but glycogenolysis alone is capable of taking care of 18 hours as well. Okay, answers are a yes, my dear friends. All of you people are also telling me the mnemonic that we have studied, that is TBG. TBG stands for thiamine before glucose. Thiamine before glucose is the gold standard approach that we have to remember in a case of Wernicke-Korsakoff syndrome, chronic alcoholic patients, weakness, lethargy. Not entirely true. Stories are not entirely true. That means he is confabulating behavior. On examination, global confusion, nystagmus, ataxia, classical case with confabulation, with stories not entirely true, fake stories, vague stories. That's the word they usually use. They use the word as vague stories, but vague stories word if they use, my dear friends. Thiamine before glucose is the best possible treatment once you ship the patient to the ICU. Okay, what is the option that we have to remember, beta? First is injection of C, then it is A, then it is B. As per our options order, please remember, first we should go for C, then we should go for A, then we should go for B. Injection of vitamin B12 actually is not required over here if this patient is having any further neurological involvement, where you are seeing flexor or extensor muscle damage, or there is position vibration senses gone, then you can add those vitamin B12. कभी कभार ऐसा होता है, a patient of pre-existing B12 deficiency suddenly might start consuming alcohol and then can land into this Wernicke-Korsakoff syndrome, where the B1 deficiency is also the cause. तो कभी कभार real life में ऐसा भी होगा. Sometimes in real life you will feel such patients where it is a case of Wernicke-Korsakoff syndrome in a pre-existing case of vitamin B12 deficiency, and that's why in that year in the question B12 injection is also given. B12 also sometimes is required in patients of Wernicke-Korsakoff syndrome as well, but for that you need to prove that B12 deficiency is indeed there. Either you have taken blood sample, send it to the lab, you have report of CLIA available, and then you can easily go for injection of the vitamin B12 as well, which will be good for the neurons as well, right? CAB, great answer CAB. Okay, आगे बढ़ते हैं बेटा. But in this question I want to just highlight some extra additional point better. Please remember, usually as discussed in the class, Wernicke's encephalopathy part, it is mainly an acute problem. That's why it is an acute emergency. That's why they also write the word as immediate. हम लोग क्या करेंगे? Please remember, immediate. ICU, immediate management, na? Immediate. ICU for immediate management. For immediate management means we are talking about the acute problem, and for the acute problem mainly we rely on the Wernicke's encephalopathy features. एक बार देख लेते हैं, 2 मिनट दे दो. Please remember, mental status changes are there where you talk about confusion, delirium, apathy, lack of focus and severe disorientation. These are the words which can also be given. हर बार ऐसा जरूरी नहीं है that they will give you this exact word, chocolate word, global confusion. This I have given. But in the MCQ, in the real life exam, sometimes the word global confusion might be confusingly given as these words. Confusion तो ठीक है, but they can use the word as delirium, apathy, lack of focus, serious disorientation. Still you have to think in that encephalopathy line only. Ocular disturbances, I have talked about nystagmus. Abnormal eye movements, they can also write it as to and fro, abnormal movements of eyeball. They can also sometimes use these three beta. Please remember, diplopia, double vision, ptosis, drooping of eyelids, strabismus, squinted type of vision. Please try to understand. These are the words which can also be used. Please do not miss this beta. Extra thing discuss कर रहे हैं एग्जाम से पहले, so that you are fresh, so that you can remember. These are the words which can be also given in case of eye problems. Ataxia. They can also give you like unsteady gait, wide based gait, short stepping gait, and inability to walk without assistance. Ataxic gait. These are the words that they can also use. Sometimes this sort of questions will be also added with any of this. Vomiting might be there, weight loss might be there, peripheral neuropathy chances will be there, as well as hypothermia is one of the problems that we might see in some cases of Wernicke's encephalopathy. Coming to the psychosis part, chronic phase, chronic problem, because the patient is daru, khamba, or some other problems like what I am having now. Jokes apart, कुछ नहीं किया है मैंने, टेंशन मत लो, घर वाले भी वीडियो देख रहे होंगे, फंसा मत देना मुझे भाई. कोर्साकॉफ साइकोसिस और chronic phase, my dear friends. In the question we have mainly seen confabulation, inventing memories to fill gaps, खुद ही connecting the dots. I told you this word, connecting the dots. Please try to understand, connecting the dots without intent to deceive. वो जानबूझ के ऐसा कर रहा है, ऐसा नहीं. It is not like that कि he intentionally is doing this, but he is so much under the influence of alcohol or narcosis that he is creating up, cooking up vague stories, telling lie to the partner. Please try to understand the Goa story that we have been discussing. However, they might also give you some other surprising data beta, जिसको पैनिक नहीं होना है. Inability to form new memory, that is anterograde amnesia, or patchy loss of the old memories, retrograde amnesia. This can also be given. They might not use the word as creating fake stories. They can also cook up some words with either anterograde or retrograde type of amnesia. गजनी बना सकता है पेशेंट को. Please try to understand anterograde amnesia as well. Behavioral changes, अचानक agitation, apathy, emotional hallucinations, particularly seen if the answer goes for delirium tremens. Oh my God. Please try to understand, my dear friends. Withdrawal. Please remember, behavioral changes. Then the answer will also go for delirium tremens. If there is sympathetic overactivity, agitation can also be there. Try to understand this. And lack of insight. Patients often are distressed by their memory. उसको कुछ फर्क नहीं पड़ेगा. He doesn't give a damn कि what is going on with him. He is creating problem for all people surrounding him, but he is cool. वो मजे ले रहा है. Please, patient often aren't distressed by their memory loss. He is not bothered. So these are the things that we have to remember, beta, that Korsakoff psychosis mainly comes in the chronic phases, whereas encephalopathy comes in the acute phases. I have clearly demarcated some extra additional points over here. Please do make a note of this in case you remember this. Very good, important, because sometimes they can play with the words. Instead of these three classical triad, they might use some other words which we have discussed just now. Question number 9. Yes, my dear friends. Yes, you are thinking exactly in the right line, because in this particular case, the image has actually helped us. Zooming in first on the image. Zooming in first on the image. What can you see? Yes, all of you are able to see this line. Sometimes there is also a central fissured line over here. These are the classical appearance of a fissured tongue appearance. Fissured tongue appearance, my dear friends. And fissured tongue appearance, my dear friends, please try to understand. It is quite commonly associated also with the vitamin B12 deficiency. So what was the question? 73-year-old, quite an old lady, 6-month history of diffuse weakness, pins and needle, bilateral arms and legs. Neurologic examination shows extensor flexor muscles of the lower extremities. Sensation vibration position also decreased in all 4 limbs. Tongue changes are depicted in the figure and examine. My dear friends, I am asking, what is the diagnosis? See, here the most likely deficiency is B12. But if you want to write the diagnosis in your prescription, what will you write? What is the diagnosis of this lady? Diagnosis first, सबसे पहले इसको बोलो. Diagnosis first बेटा. Prescription में diagnosis क्या लिखोगे? What will you write in the prescription? Peripheral neuropathy ठीक है, नहीं. I want the exact word. We have studied in our notes in the lipid chapter later on, my dear friend. What was the diagnosis? मेगालोब्लास्टिक एनीमिया. नो, देखो यहां पर तो एनीमिया के बारे में बात ही नहीं किया है. नो, व्हाट इज द डायग्नोसिस यू विल राइट. Look at the neurological changes and think and remember where did we study about this. Yes, my dear friend, this is called as SCD, not SCID. SCD. What is SCID? SCID was severe combined immunodeficiency. That was different. But this is what? Subacute combined degeneration. Yes. This is the diagnosis as a neurologist or as a MD medicine guy you are supposed to write in your prescription. Subacute combined degeneration is the diagnosis of this patient, where the cause of this is primarily due to B12 ka deficiency. B12 deficiency is the cause, but the diagnosis is SCD. Subacute SACD or SCD is the word that we can remember. Subacute combined degeneration. And in this we have also studied that extra additional point. We can see 2 more signs also becoming positive. We have studied Romberg sign positive, and my dear friends, Babinski's sign also positive. Babinski's sign also will be positive. Please remember. Can we also see glossitis in patients of B12 deficiency? Answer is yes. We can also see some amount of the glossitis. Glossitis is where we are having redness and shininess, glossy tongue. Glossitis look like reddish strawberry colored tongue. But there is also something called as geographic tongue. Please do read about this from dermatology. Geographic tongue, where we are actually having a map like pattern. There are different disorders. There are more than one disorders where we get to see geographic tongue, where basically it will look like somewhat, if I just change this image to some extent, you will be having some clear cut demarcation. It will be having some clear cut demarcation where the areas, there will be having some indurated margins like this. You will be having some indurated margins like this, and this is called as the classical geographic pattern. Rest of the tongue will be okay, but only in that you will be having patches, patchy discoloration with some indurated margin like this. So that is the geographic tongue, my dear friends. Please try to remember this beta. And riboflavin deficiency, some patients of psoriasis can also patients with the geographic tongue as well. So please remember. There is also something on Michelson-Rosenthal syndrome. In that also you can also get to see that. So no need to go into too much detail. Just try to understand better that try to learn between the fissured tongue and the geographic type of appearance, and glossitis is different. Please watch out for these three images which has been asked in your exam. Plain glossitis image, fissured tongue image, and map like pattern geographic tongue image. 3 different answers for 3 different type of questions. Please remember. B2 deficiency, you have cheilitis, cheilosis, angles of the mouth, angular stomatitis. Those things are not mentioned over here. Yes, cheilitis, cheilosis, glossitis can be also seen in both B2 as well as in B12 deficiency. But in B2, my dear friends, angular stomatitis must have been also mentioned. And in case of B2 deficiency, you do not get to see this much of neuronal involvement. ये क्वेश्चन चीख चीख के हमें बोल रहा है. दिस क्वेश्चन इज इटसेल्फ टेलिंग अस दैट प्लीज चूज द आंसर एज B12 because here there is mainly neurological problems which are more predominant over here, but right, this cannot go for B2, it will go for the B12 deficiency. B1 and B6 are both important for nerve conduction. B1 deficiency, B6 excess, B6 deficiency both can lead to tingling sensation. B12 deficiency from the vitamin list is the most common cause. Overall cause of B12 deficiency most common, I told you, diabetic neuropathy. In worst case scenario, sometime B2 deficiency can also present with the tingling, that is the remote cases. But pins and needles in this question is nothing but the tingling sensation word that we have to watch out for. B6 INH, yes, INH, that is isoniazid. Okay, मैप लाइक पैटर्न. चलो ठीक है, ये क्वेश्चन क्या है? बोले सर आज क्या क्या क्वेश्चन दिखा रहे हो, क्या पता भाई, आई डोंट नो. B9 alone cannot cause tingling. If the cause of B9 deficiency is due to B12 deficiency, then the patients will also show you tingling sensation, like due to folate trap. Yes, that question also we have discussed. वुल्फ आ गया, पार्किंसन आ गया. यस, पार्किंसन आ गया, विल्सन आ गया, विल्सन आ गया. एनीवन वांट टू चेंज द आंसर? समबडी फॉर हंटिंगटन और ATP7 है. माय डियर फ्रेंड्स, हंटिंगटन भी आंसर आ गया. ले भाई, हंटिंगटन. बेटा 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 बेटा, सबसे पहले ये समझो, इमेज हैज बीन गिवन एज एन एक्स्ट्रा हिंट. इमेज हैज बीन गिवन. ट्राइंग टू कोरिलेट दिस क्वेश्चन विद बायोकेमिस्ट्री, मेडिसिन एंड रेडियोलॉजी. तीनों को मिक्स करके ये क्वेश्चन है. थोड़ा सा देखना पड़ेगा हमें आंसर आराम से. ओके, लेट अस रीड द क्वेश्चन. पांडा साइन, यस माय डियर फ्रेंड्स, पांडा साइन. सैयद, yes. Lakshman, Apurva, yes. Panda sign, yes, 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 yes. Let us, yes. This, my dear friends, try to look over here, zooming in the image. Look at the center over here. This is the face of the giant panda sign. Yes, my dear friends. This is the image of the panda sign, my dear friends, that we have to remember over here, beta. Panda sign, and this is seen in case of Wilson disease, lentiform nuclear changes. Try to understand, my dear friends. Panda sign, yes. So as you guys have correctly pointed out, this is a case of Wilson disease. This is due to ATP7B gene mutation. क्वेश्चन को एक बार देखते हैं. ओके, थोड़ा सा कुछ सीख भी लेते हैं. 42-year-old male, medicine, difficulty in speech, writing for last 4 years. We have been discussing in case of Wilson disease, there is a word called as dysarthria, slurred speech, difficulty in speech. Also there is problem with the dyslexia as well, writing for last 4 years. Last 1 year, recent difficulty in performing any work for the last 6 months, things are getting worsened. Slurring of speech, low volume gait was linking. T2 weighted image show high intensity in the midbrain tegmentum and the lentiform nuclei. See, even though if you have not been able to pick up the image, but you should have paid attention to this nucleus damage, lentiform nuclear, and it is showing hyper intensity signal, high signal intensity. That means something must have gone wrong in the lentiform nucleus area. And please remember, LFT showed increased ALT, decreased albumin. That is another added feature of the Wilson disease, because the liver is undergoing hepatocellular degeneration, my dear friends. And ultrasonography also has confirmed hepatic ecotexture and liver biopsy cirrhotic changes. I told you, Wilson disease, if it is not corrected on time, ultimately eventually the patient will end up having cirrhosis. So lentiform nucleus albumin low, ALT high, hepatic coarse echo texture, cirrhotic changes. Wilson disease should be thought of. Parkinson disease, Huntington's disease, ATP7 gene mutation is that Menkes kinky hair syndrome. In that we do not see this sort of changes beta. So even though this image is not given in the exam, but we should be able to pick out this. Now let us try to learn something new over here. Let us start with this beta. Wilson disease we have been discussing. ATP7B gene mutation, chromosome 13 is the word. Caseous Fleischer's ring we have discussed. Copper will coming out high level in the urine, low cellular plasmin level and high free copper level also in the blood. Lenticular degeneration, all of you know lenticular nucleus, two parts, globus pallidus, putamen, inside, outside, outer part, inner part, all of you know this. Globus pallidus and putamen to work together. This is the face of the panda, which basically looks like, let us try to focus on this face of the panda thing beta. See, please remember, this image is jokes apart, but look at this image. This is the face of the panda sign that you are able to see in this particular zone beta, midbrain tegmentum. Why it is called as panda? Try to quickly remember, although many of you know it from the radiology. Please remember the hyper intense regions that you are able to see over here. The hyper intense regions are the tegmentum of the midbrain. That was written in the MCQ as well. Red nuclei normal appear as the eyes, and the substantia nigra pars reticulata part basically forms the ears. So basically in this panda image, hyper intense areas, my dear friends, are the tegmentum of the midbrain. This is the hyper intense area, my dear friends. Then we have the normal and normal eyes and the ears. Normal red nuclei is the two eyes over here beta ji, and two ears, my dear friends, that you are able to see over here. These are formed by the help of the red nuclei and the substantia nigra. And the hypointense area, superior colliculus, resembles the mouth. Please try to understand, यहाँ पर एक छोटा सा mouth भी है in this hypointense area. This is the superior colliculus which resembles the mouth. Together these structures resemble the face of the panda. इसको कभी कभार लोग face of the giant panda sign भी बोलते हैं. Please try to understand. So although all of this you don't have to remember, but at least try to focus on the face of the giant panda time. And during our classes we have also talked about tremors, and this case the tremors are somewhat like this. I'm not able to show you. If you stretch your hand, then the tremor that we get to see, this is also having a peculiar name beta. याद रखने का कोशिश कीजिएगा. This is called as the famous wing beating tremor. This thing we did not discuss during the classes. It is something extra, wing beating tremor, that we have to remember beta. Yeah, lenticular degeneration के बाद, because of this we are also having problems with our coordination as well as the tremor that we are having over here. This is called as the flapping of a bat like thing. That's why we call it as a wing beating tremor. But इसको भी नाम थोड़ा सा एक बार देख लीजिएगा. These two are important, that we have to make a note of this. Now basically we try to look for these problems in the Wilson disease. Coarse hepatic echo texture, all of us have known. Jaundice हो सकता है, anorexia, nausea, vomiting are common thing, liver pain common thing, dysarthria, that is the slurring of the speech that we have discussed. It can be dystonia. Tremor का नाम हमने देखा, wing beating tremor is the word, and the ataxic gait can be also seen in patients of Wilson disease. Mental health problem में irritability, aggression, antisocial behavior, anxiety, and we wrote something extra, that is real life experience, mood swings in male. हम लोगों ने लिखा था. Please remember, I'm adding it one more time, जो हमारे notes से है. Mood swings in case of male. Mood swings in male, my dear friends, also is an added problem that we are able to see. Ocular symptoms, all of you know, sunflower, sunray, sunburst, cataract, caseous Fleischer's ring in the decimate membrane. What is the treatment, my dear friends? The treatment, my dear friends, treatment में, I know many of you have been putting also me message. Now as medicine faculties are also focusing on this, that's why I'm writing this one first. Penicillamine, then if not trientine. After this session there should not be any confusion beta. And we can also go for zinc acetate therapy for the lifelong thing. Emergency basis penicillamine. But again I have also shared a message to many students through personal WhatsApp that though penicillamine is preferred on the MCQs on the exam day. But please do remember, penicillamine comes with a lot of side effects which are not so much prominent in case of trientine. That's why many clinicians in India are gradually shifting towards trientine more and more than giving penicillamine. Exam day पे भले ही answer penicillamine हो, but real life cases में sometimes you will be seeing clinicians, consultants are nowadays preferring trientine. But yes, something has to be answered on the exam day. If both the options are given, please choose D penicillamine. But do keep it in mind, D for danger. Do keep it in mind. D penicillamine is a dangerous word. Dangerous word. D for danger. Clearly लिख के दे रहे हैं, D for danger. Real life में इसको avoid करना ही चाहिए. You can see these two type of treatment available, but depending on where you are getting placed, what your seniors are telling, your HODs are telling, that you have to listen to that. किसी किसी को डी पेनिसिलामिन से ज्यादा लगाव हो सकता है. Some people might choose trientine, but trientine comes with less side effect. If you have time, do search difference between trientine and penicillamine response in the patients of Wilson disease. Search in the internet, you yourself will be seeing trientine is much more safer than the penicillamine. That's why I'm clearly writing over here, no confusion. This is safer drug. Trientine ज़्यादा safe होता है. Answer इसको करके आना, penicillamine as per medicine answer. Quoting a famous line beta from one of the great guy, everybody knows who Abraham Lincoln was. And my dear friends, your future totally is on your hand. The best way to predict the future is to create it, which you are in the process of making it now. And 17 January is the day where success, my dear friends, will be yours. Please remember. So this is the word. Please do keep it in mind. आगे बढ़ते हैं. आज थोड़ा बड़ा बड़ा क्वेश्चन दे दिया है. ये क्या है? Lengthy questions. Sometimes paper can be lengthy as well. Yes. Try to cope up. Yes, paper can be lengthy as well. Sometimes it has also happened in the past that in the exam day, in 1 minute time, students were not able to read the full question. Answer करना तो छोड़ो. 1 मिनट पे पूरा क्वेश्चन पढ़ के समझ में ही नहीं आ रहा था. ऐसे भी FMG हुए. I'm not here to scare you, but this is the reality, beta. Sometimes you have to play smart. In a long history, you need to find positive findings. That's why I always use the word positive findings. Try to watch out for that. Information might be huge, but काम का चीज with which we can do the diagnosis, that we need to identify. Yes, try to watch out for those words, my dear friends. देखो, ढूंढो कहां पर है ये, ढूंढो. बिग क्वेश्चन, आई कैन अंडरस्टैंड. 1 मिनट तो क्वेश्चन पढ़ने में ही चला जाएगा, बट क्या है ये? ओके, आंसर्स आर कमिंग. आई डोंट नो. भाई एडा तो ऑप्शन में ही नहीं है. हेलो मीमियम, किसी ने एडा आंसर किया था. एडा, अरे एडा है, एडा ऑप्शन में है. सॉरी सॉरी सॉरी, एडा ऑप्शन में है. यस यस, एडा ऑप्शन में है. यस यस यस, सॉरी मिस्टेक. आई वाज नॉट फॉलोइंग, आई वाज जस्ट गिविंग ज्ञान, सो आई मिस दैट. यस yes, my dear friends. Yes 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 yes, exactly, all of you are right, beta ji. 4-month-old female child, pediatric OPD, pneumonia, irritability and seizure, was not improving on treatment for more than a week. Yes, you are on the right line, referring nursing home. She's also featured congestive cardiac failure, failure to thrive. 2 months for pneumonia and another hospital. Chest X-ray confirmed features of pneumonia. 2D echo showed dilated cardiomyopathy. Yes. Near total loss of T and B lymphocytes with low IgG levels, low immunoglobulin levels. This is the master stroke over here. Big history, but watch for the correct. Though she received dose of IV immunoglobulin together with appropriate antibiotic, prophylactic, antiviral medication, but died within the few days. Lethal. All of you are correct. All of you are correct. This is a case of SCID. It is not the SCD. That was subacute combined degeneration. This is the case of SCID, severe combined immunodeficiency, and all of you have given the right answer, beta. This is due to the deficiency of the enzyme ADA, adenosine deaminase. Yes, all of you are right. Adenosine डियामाइनेज डेफिशिएंसी, ये स्किड। ग्लोबल कंफ्यूजन हो गया था मुझे, प्लीज रिमेंबर। एंटेरोग्रेड एमनेशिया, ओ माय गॉड, ज्ञान देते देते भूल गया कि क्या पढ़ा रहा हूं। चलो ठीक है, यस यू आर देयर टू करेक्ट मी, थैंक यू सो मच। ओके, व्हाट अबाउट द other three enzymes deficiency? HMB synthase, all of you know. Hydroxymethylbilin synthase deficiency, my dear friends, HMB synthase deficiency, please remember beta ji, this is acute intermittent porphyria. Acid maltase deficiency, this is the Pompey's disease. Homogentisate oxidase deficiency, all of you know, this is Alkaptonuria. This is Alkaptonuria, right? These three को भी एक बार देख लेना. These are the three other things. Adenosine deaminase, very fatal, very lethal, and all of you know one important milestones for all of us in the whole world. The first successful gene therapy was implemented for the treatment of severe combined immunodeficiency. Please remember, and a first successful gene therapy. Nowadays you have gene therapy options for some other disorders as well, but पूरी दुनिया में पहली दफा जीन थेरेपी इसी डिजीज को ट्रीट करने के लिए किया गया था, राइट? इंपॉर्टेंट पॉइंट, आगे बढ़ते हैं। यस, ओके, व्हाट इज दिस क्वेश्चन? बाप रे, आज तो क्वेश्चन ही क्वेश्चन, क्वेश्चन ही क्वेश्चन, ओ माय गॉड। मोस्ट कॉमन कॉज ऑफ डेथ वाज न्यूमोनिया। यस, ग्लोबल कंफ्यूजन मुझे हुआ था, ठीक है, वो मैंने देख लिया। अभी ये क्या है? हाँ, डुबिन जॉनसन, हेलो, we are at 12 question, number 12 question. Okay, vampire's disease, yes, 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 you are right beta ji, exactly, you are right. Vampire's disease question, vampire's disease, yes. So what is the answer? Rare form of porphyria, yes, vampire disease, rare form of porphyria. Tough question पूछ लिया, rare form of porphyria, vampire disease. Which enzyme deficiency beta ji? Which enzyme deficiency? Vampire? No, 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 no. Uroporphyrin decarboxylase PCT. Oh, ho. No, 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 no. This deficiency is called as Porphyria cutanea tarda. Uroporphyrinogen 3 synthase deficiency, my dear friends, is the vampire's disease. This is the vampire's disease, also called as congenital erythropoietic porphyria or CEP. Uroporphyrinogen 1 synthase deficiency also can be marked as acute intermittent porphyria. We have discussed during the classes, acute intermittent porphyria can be marked with three different enzymes names: HMB synthase PBG deaminase or coproporphyrinogen, uroporphyrinogen 1 synthase, and uroporphyrinogen 3 synthase vampire disease, and coproporphyrinogen oxidase comes later inside the pathway, later, please remember. So first these three we have been mixed, that's why I'm focusing only on these three. Now the diagnosis was right, vampire disease, but the answer you chose a little wrong beta. यहाँ पर सबसे पहले correct answer को mark करते हैं. This is going to be the uroporphyrinogen 3 synthase. Mainly these are the three disorders from where question has been asked in our exam beta: PCT, AIP, and congenital erythropoietic porphyria or vampire disease. Now let us see the question. 27-year-old male, medicine OPD, reddish brown staining of teeth, matching with the vampire disease. Blisters formation when exposed to sunlight for a long time. Occasional passage of dark red colored urine. Dermatology, biochemistry refer, okay, secondary opinion. Coproporphyrin 1 levels are high, and that explain the risk of photosensitivity and diagnose the case as rare form of porphyria. Classical triad of vampire's disease has been mentioned: staining of teeth, And please remember, excessive photosensitivity also has been mentioned, and they have clear cut given the image of a blister on the sun exposed areas on the hands. If I zoom in, you are able to see the clear cut blister over here, and the patient is able to pass dark red colored urine, and this is sometimes also called as port wine color. Please write, very very important, this is sometimes also called as port wine color of urine. This we did not discuss during the class, something extra, port wine color. हमेशा कोला कलर नहीं देगा, प्लीज रिमेंबर, दिस इज नॉट कोला कलर, दिस इज नॉट मैजेंटा रेड कलर, दिस इज कॉल्ड एज पोर्ट वाइन. Port wine color is the word that we also get to see in the patients of vampire disease beta. And to explain why there is a raised level of coproporphyrin 1, let us try to quickly have a look at the pathway. This was the image of the Harrison. Zooming in, our topic is congenital erythropoietic porphyria, vampire disease. That is the deficiency of the uroporphyrinogen 3 synthase, right? If this enzyme is gone, we can all understand the precursor, that is hydroxymethylbilane, this will become increased. Now there is a traffic jam in the normal route, because this normal route was blue in color. That's why I chose, you will open up GPS now and you will send the hydroxymethylbilane to a red color pathway, and in the red color pathway, this first step does not require any enzyme. On the right hand side, in the blue color pathway, you require this uroporphyrinogen 3 synthase, which is absent in the vampire disease patient. So the normal pathway cannot go till the production of the heme, that is not possible. But the other backup pathway in this step does not require any enzyme, so by which it will be converted to something called as uroporphyrinogen 1. And surprisingly, this guy can take the benefit of the another enzyme. This is present because this enzyme is absent in a separate disorder called as Porphyria cutanea tarda. This is not a case of Porphyria cutanea tarda, this is a case of vampire disease, that is congenital erythropoietic porphyria. That means here inside the liver or in the bone marrow of that patient, this enzyme is actually present. uroporphyrinogen decarboxylase is present. ये एंजाइम है, इसके पहले वाला एंजाइम नहीं है. The enzyme before that is absent, but this enzyme is present, and that's why this uroporphyrinogen 1 can now, by the help of this enzyme which is present in the liver, can be converted to coproporphyrinogen 1. And this coproporphyrinogen 1, whenever there is a sunlight exposure, it can be converted to a toxic substance which is called as coproporphyrin 1, and this coproporphyrin 1 name was given in our MCQ. If you just go back and see one more time, raised level of coproporphyrin 1, this is how it is becoming a marker of choice for diagnosis of vampire disease, because coproporphyrin 1 is the guy that will finally come out in the mutra visarjan of this patient. And whenever this is coming out in the urine, the color of the urine sample also will become that classical port wine color. These are the two extra points that we are discussing it today in the 25 most important session. Please do make a note of this. Port wine color इसी चीज के साथ होता है, and this is the guy which is coming out in the urine. port wine color. So please remember. So this is some pathognomonic feature and pathogenesis in case of Wilson disease. Sorry, in case of vampire disease, beta. Acute intermittent porphyria and Porphyria cutanea tarda, their mechanisms we have already discussed during the classes. Just to do a quick recap. HMB was the guy, hydroxymethylbilane. It should have been converted by the blue color route. Enzyme name is called as uroporphyrinogen 3 synthase. That is not present. I told you also some book call it as co-synthase. आपको याद होगा. In the notes we also wrote that this 3 synthase is also sometimes called as co-synthase, but this route is not possible. This route is not possible. That's why the other alternate route is now taking him to a different guy, and it is getting converted to that uroporphyrinogen 1 to finally coproporphyrinogen 1, that is finally to coproporphyrin. Please remember this. This is how the pathogenesis basically is done for the vampire's disease. Please remember. So it is a question of vampire disease where they can either show you this image or they can show you this blisters image on the hand. And another important hint that we have discussed over here, beta, it is the rare form of porphyria. Rare form of porphyria. Please remember this, rare form of porphyria. आगे बढ़ते हैं. Easy questions. Answer please. केस क्या है? सबसे पहले what is the diagnosis, what is the case? Yes, all of you are thinking in the right line, beta. Let us see quickly. 15-year-old female, chronic headache, okay, become daily for the last 3 months, wakes up at the middle of the night, past treated with musculoskeletal pain, synco, fatigue, hypermobility of the joints. At the age of 10, difficulty in chewing as there was missing deciduous teeth. There is also delayed eruptions of the permanent teeth. She can now do the following as well, that is this image that they are talking about. My dear friends, over here, missing deciduous teeth, diagnosis of collagen vascular disorder, and in this case, beta ji, this diagnosis is actually not going for Marfan syndrome, beta. Here the diagnosis is going for Ehlers-Danlos syndrome. थोड़ा सा बाउंसर है ये क्वेश्चन, आराम से, पैनिक नहीं होना है. Ehlers-Danlos syndrome, EDS. Please remember, in the EDS mainly we talk about hyperstretchability of the skin, hypermobility of the joints. This hypermobility of the joints is also there, but this is quite common also in case of Marfan syndrome as well. But please remember, some other extra history is important over here that has to be taken into consideration. What is the other hint over here, beta जी? इसको थोड़ा सा देखते हैं, ध्यान से देखो. Missing deciduous teeth. Yes, this is also possible in case of Ehlers-Danlos syndrome, some of the form. There are total 13 types of Ehlers-Danlos syndrome, my dear friends, in the whole world. It is humanly impossible for anyone to remember all the clinical features. बहुत सारे types होते हैं, classical type, hypermobile type, बहुत dermatopraxis, बहुत सारे type होते हैं बेटा. There is Villefranche classification, Berlin's classification. Not need to go into the detail, but please remember, sometimes EDS patients can also present with chronic headache. Chronic headache. Sometimes they also use the word as cluster headache as well. EDS patient में ये भी common है, that wakes her up also at the middle of the night. Please remember, musculoskeletal pain, synco, fatigue, and there is also delayed eruptions of the permanent teeth. These things are adding extra advantage for the Ehlers-Danlos syndrome. ये सब चीज Marfan syndrome में नहीं दिखते. Marfan syndrome doesn't come with this, beta. And not 6 types, beta. Not 6 types. 6 types I mentioned only for the FMGE exam. Only for the FMGE exam, beta. But if you do Google it, beta, चाहो तो अभी Google कर लो. Total in the whole world there are 13 types of Ehlers-Danlos syndrome. वो बड़ा classification. I'm not here to teach you that. Nothing to panic. Total 13 types होते हैं बेटा. हम लोगों ने तो बहुत कम कम करके पढ़ा. So Ehlers-Danlos syndrome, beta, 13 types. Now in this, see, you are stuck with 2 options. Either you have to mark the answer as type 3 collagen, or you have to answer as, type 3 or type 5. Type 3 or type 5 collagen. But as in this image, hypermobility has been preferred. Listen to me carefully. Hello, don't get distracted. Listen to me carefully. If you are getting this sort of image where hypermobility feature has been highlighted particularly in the image, then my dear friends, best possible answer we should mark it as type 5 collagen. This is the best possible answer of this one. Please do make a note of this. Hypermobility is mainly feature over here that is highlighted in the image. Type 3 में भी होता है, but type 3 mainly skin oriented problems are more than the joint oriented problems. But in type 5, joint oriented problems are more than the skin oriented problem. Just try to remember this बेटा. ऐसा image के साथ अगर Ehlers-Danlos syndrome diagnose कर रहे हो, it is safer to go for the answer as type 5 collagen. अच्छा, in this question, if I add some extra history, ruptured aortic aneurysm, what will be the answer? I add one more thing. At the age of 32, she dies in the ICU due to ruptured aortic aneurysm. Same question, same image. Now what will be the answer? पंद्रह साल में ये प्रॉब्लम हुआ, 32 साल में लड़की मर गई. She dies at the age of 32 due to ruptured aortic aneurysm. Then my dear friends, what will be the answer? Yes, exactly, you are right beta ji. In that case our answer suddenly will become type 3 collagen, because type 3 collagen is the vascular type and this is the most fatal type as well. This is the most fatal type. So please remember, any aortal or valvular or venous damage, capillary damage, aortic rupture, mainly if there is any vessel related problems has been given to the MCQ as an extra additional point, then the safest answer to go for is type 3 collagen beta. These are the two important points that we have to watch out for, because that question also has been asked in our FMGE exam as well. ये ADS का केस था, मार्फन सिंड्रोम में ये सब डेसिडुअस टीथ वगैरह मिसिंग वगैरह नहीं होते हैं बेटा. डिलेड इरप्शन, permanent teeth eruptions, problematic, these things are not a feature of Marfan syndrome. Okay. आराम से, हेलो, डोंट रश, आराम से पढ़ो, टाइम है. In the question only diagnosis has been given, so diagnosing the case is not a challenge. Whether you know something about the diagnosis is not or not, that we have to remember. Just a moment. Bapre, many options are coming. Brittle bone disease is osteogenesis imperfecta beta, वो अलग है, type 1 collagen defect that we have discussed. Brittle bone disease, osteogenesis imperfecta, type 1 collagen defect. Most common gene mutation is collagen 1A1 gene mutation. We also have blue sclera, kyphosis. Then we have got those kyphoscoliosis changes. Then we have those bowing of legs, deformed teeth formation. There we have deformed teeth formation. Here there was delayed teeth formation. One is deformed in case of osteogenesis imperfecta, another one is delayed in case of Ehlers-Danlos syndrome. Please do make a note of this beta. Thank you. See, it is a case of Reye syndrome. सबसे पहले देखते हैं आराम से. This is a new thing that we are studying. कोई बात नहीं, if you have missed this, आराम से 2-year-old मेल ना बोल के बॉय बोलना चाहिए था. 2-year-old boy, 2-year-old child, influenza like symptoms, neurologic deterioration, elevated liver enzymes, creatinine elevated, hypoglycemia, evidences of hyperammonemia, metabolic acidosis and convulsion. Please remember, eyes on me, very important. Classical triad of Reye syndrome is this. Please remember, these three things together is called as the classical triad of something called as Reye syndrome. REYE, Reye syndrome is the diagnosis. Hyperammonemia होता है, lactic acidosis for which metabolic acidosis and convulsions are also a feature. Which of the following mechanism best explains the pathogenesis behind this disorder? Actually my dear friends, the question answer over here is the A. सबसे पहले क्वेश्चन का आंसर मार्क करते हैं बेटा, दिस इज ए. अभी समझते हैं कि ये रेई सिंड्रोम है क्या. फर्स्ट ऑफ ऑल, मेनी ऑफ यू हैव मार्क्ड द आंसर as this type C, I mean the option number C, deficiency of ornithine transcarbamylase in the urea cycle. Actually you have thought in the right line, nothing to panic, you are good, you are great beta. Try to understand, your thought process took you to the right direction only. Deficiency of ornithine transcarbamylase, all of you know this is the case of type 2 hyperammonemia, right? Type 2 hyperammonemia, this is the urea cycle defect. And my dear friends, ornithine transcarbamylase. Now the problem over here is this, try to understand beta G. If it is a case of type 2 hyperammonemia, ornithine transcarbamylase deficiency, then in this particular question they must have mentioned about some other extra feature, glutamine increase in the blood, or they must have mentioned something called like orotic aciduria in the question as well. आराम से समझो, नथिंग टू पैनिक, गलती से सीखना है हमें, राइट? दे मस्ट हैव मेंशन्ड अबाउट दिस टू बिकॉज ग्लूटामिन लेवल डेफिनेटली राइजेस, यूरासिल, or they can also write it as uracil rise in the blood, but none of this feature my dear friends has been mentioned over here. आप लोगों ने हाइपर एमोनेमिया वर्ड देख के, मेटाबॉलिक एसिडोसिस वर्ड देख के, कन्वल्शन देख के सीधा यूरिया साइकिल डिफेक्ट की तरफ चले गए हो. दैट्स व्हाई you have gone in the wrong direction. But try to understand my dear friends, here they have not talked about any of these three features. Glutamine rise is not given, orotic aciduria is not mentioned, uracil rise in the blood is also not mentioned. This specifically rules out our option number C. Sometimes even if you don't know the right answer, we need to rule it by rule of exclusion. Please remember, deficiency of carbamyl phosphate synthetase 1 urea cycle, that is the type 1 hyperammonemia. All of us know that is the type 1 hyperammonemia. Here the patient will not survive. I told you, 2-year-old, this sort of type 1 hyperammonemia patients usually go to the ICU but they never come out, and it is a life-threatening type of disorder where we have massive hyperammonemia. Massive hyperammonemia. Please try to understand. So in this case, this also cannot be the answer over here because the child has been able to live for 2 years. Now coming to the first two, see, defect of or decrease of UMP synthase in the pyrimidine synthesis, UMP synthase deficiency, this actually leads to primary orotic aciduria. Primary orotic aciduria, this is also your exam question beta, FMGE exam question, because UMP synthase enzyme is actually having two type of activity. UMP synthase, let me write it over here beta, let us learn something. UMP synthase enzyme, it is called as orotidine phosphoribosyl transferase plus orotidine monophosphate OMP decarboxylase. These two name was recently asked in your FMG exam beta, that primary orotic aciduria is due to which of the following enzyme defect. You can mark the answer as UMP synthase, but UMP synthase is a bifunctional enzyme, it is having two different type of function, so either they can give you a mixture of OPRT or OMP decarboxylase as well. This is the option that they give in your FMG exam beta, but they can also give the option as UMP synthase. So please remember, primary orotic aciduria is due to this, either the common name or the two-part name. UMP synthase is a bifunctional enzyme, it has got phosphoribosyl transferase activity or decarboxylase type of activity, both the activity, that's why it is called as bifunctional enzyme. So primary orotic aciduria, but again in this question orotic acid has not been mentioned, so that's why option number B is also ruled out, option number D also ruled out. So by rule of exclusion we have to choose the answer. Now what happens in case of Reye syndrome? In case of Reye syndrome, mainly there is this enzyme that is present. Type 2 hyperammonemia, what was the problem? It was deficiency of ornithine transcarbamylase. OTC was the enzyme, right? OTC was the enzyme name from the urea cycle pathway. But in this case, it is actually not deficient. Rather, there is a damage to the mitochondria. आपको याद होगा, in the urea cycle total there were 5 steps. PUBG, partly mitochondria, partly cytosol. First 2 steps of urea cycle was in mitochondria, last 3 steps of urea cycle was in cytosol. So OTC, that is the second step enzyme, is a mitochondrial enzyme. And now in Reye syndrome, due to mitochondrial damage, please remember, this enzyme, although it was present, this is now leaking into the cytosol, and it is not able to work. This is what is called as Reye syndrome. If the enzyme is not present, it is type 2 hyperammonemia. If the enzyme is present but not in the right compartment, mitochondria के बदले वो cytoplasm में चला गया, that is the pathogenesis of Reye syndrome. Something new to understand. I am giving you guys a small homework, beta. Please try to understand. Small homework. Please find out Reye syndrome is actually associated with some drug. There is also a strong correlation of Reye syndrome with pharmacology. ऐसा भी हो सकता है कि अगले FMGE एग्जाम में they try to patch this Reye syndrome word with pharma and biochem overlapping question. Do read about it. You all have my number. We will connect with each other. Reye syndrome, that it is associated with which drug use, try to find out. Very, very important. Right. So this is Reye syndrome, beta. Type 2 hyperammonemia mein it is present. No, it is not present. It is absent at all. In Reye syndrome, it is present but not in the right compartment. Not in the right compartment. Please remember. Yes, aspirin. Are baapre. Aspirin. Yes, aspirin. Influenza-like symptoms. Recent history of influenza-like symptoms. Neurological deterioration due to hyperammonemia. Yes, aspirin. Associated with aspirin. Great beta. Great. क्या बात है. Question number 15 आते हैं. आराम से. Great answer, beta. This was probably an easy question as compared to the other ones. Yes. The main point over here, abnormal burnt sugar smell in urine. All of you have thought in the right line, beta. It is a case of maple syrup urine disease. Yes. All of you are right. Maple syrup urine disease, beta. And what is the diagnosis? What is the answer? Yes, B. बिल्कुल सही. DNPH test, dinitrophenyl hydrazine test. DNPH beta, right? DNPH, you are in the right line. Dinitrophenyl hydrazine test. Yes. So occasional seizures. Let us quickly see the history. 5-month-old, refusal to suck. Oh my God. Yes. Refusal to suck breast milk can be also a feature of maple syrup urine disease. During the classes, we did not discuss the clinical features of the maple syrup urine disease in detail. No, we just wrote 3 lines. Burnt sugar mill, DNPH test, as well as we have discussed about that branch chain ketonuria that is picked up by either dipstick test and that branch chain keto acid dehydrogenase complex deficiency. But let us see the clinical feature. If it is asked like this, refusal to suck breast milk is also presented like this. Occasional seizures are there. Secondary hypoglycemia, choosing an extra highlighter over secondary hypoglycemia. Maple syrup urine disease is a problem of branched chain amino acid metabolism. But this metabolism defect also will create problem for the liver to perform gluconeogenesis to some extent. That's why it is also connecting with the carbohydrate metabolism, where you can see secondary hypoglycemia, where the problem of amino acid metabolism is creating a problem for gluconeogenesis, that is a topic of carbohydrate metabolism. That's why this sort of is called as secondary hypoglycemia. Please learn maple syrup urine disease clinical features. If by chance they don't give you this hint, तब क्या करेंगे? By chance if they don't give you this hint, because of this hint question has become easy, but if they remove this, then also you have to think in the right line. Metabolic acidosis, yes, ketonuria reflected on the ABG analysis, urinary dipstick test positive, form of organic aciduria. And please remember, normal ammonia level in the blood, master stroke. That's why I'm not rushing, I'm focusing on each and every point which is important. But in case of maple syrup urine disease, you do not see hyperammonemia. Oh my god, it is a problem of ammonia metabolism, amino acid topic, but we don't get to see ammonia level high. Normal ammonia level in the blood, occasional seizures, refusal to suck breastfeed, secondary hypoglycemia, metabolic acidosis with ketosis. Please remember, answer can also go for maple syrup urine disease as well. Please do learn from this. Benedict test, all of you know, it is for all reducing sugar and reducing substances. Ferric chloride test, we have studied, it is mainly positive in case of PKU, phenylketonuria due to phenyl pyruvate, as well as it is also possible to be positive in case of Alkaptonuria due to homogenesic acid. Cyanide nitroprusside test, my dear friend, this is positive in case of homocystinuria as well as cystinuria, So CNP test, cyanide nitroprusside test, is also possible, and this cyanide nitroprusside test, my dear friend, was actually negative in case of Marfan syndrome. It is positive in case of homocystinuria, negative in case of Marfan syndrome, right? Important point, please make a note of this, beta. Yes. Okay, beta. Right, hope you have been able to approach this. Little bit word of motivation, beta ji. Tough questions I'm giving you today. I'm acting little bit weird. No, nothing weird, beta. We are just making you prepared for the worst case scenarios as well. By chance अगर थोड़ा सा tweak and turn हो गया, because you have given your lives 6 precious months. That's why it is also our responsibility to train you well, to drill you well, to grill you well, so that by chance on the exam day, if some bouncers are coming, you are not in a distraught situation that you will be leaving that question. Somehow, my dear friends, we cannot give up. We cannot give up, beta. We have given so much. We have given so much over the past couple of years, past couple of months has been quite a nightmare for all of us during these heavy schedules. I can totally understand, but we should keep it in mind that 6 years back, 5 years back, we had started with a long cherished dream that one day we will be able to practice medicine in our country. That's why you are very close, beta. You dare give up, beta. Just keep your focus high and you are almost reaching the goal, beta. And remember why you started the journey, where your parents had given their best possible thing to offer you, to give you a second chance to pursue your dream career in the future. Coming to the question number 16, last 10 question beta, जल्दी से करते हैं. दिस इज एन इजी क्वेश्चन, आराम से पढ़ो, नथिंग टू पैनिक बेटा जी, ये इजी है. थोड़ा सा आराम, थोड़ा सा आराम से, आराम से, आराम से, आराम, नथिंग टू पैनिक, व्हाई आर यू रशिंग गाइस, आराम से पढ़ो ना, कोई भाग नहीं रहा है, टाइम तो है, 1 मिनट टाइम है ना एक एमसीक्यू के लिए, दैट इज 1 मिनट टाइम, यू यूटिलाइज दैट 1 मिनट एंड देन यू आंसर ना, व्हाई आर, हाँ देखो बोलने के बाद सही आंसर आ रहा है, यस, फर्स्ट अप्रोच में ही वी हैव टू कम टू द राइट आंसर बेटा, सिंपल क्वेश्चन है रे बाबू, ये देख, 10 year old boy ओपीडी आनुवज और प्रेजेंटेशन ऑफ फिशी ओडर बोल रहा है, fishy odor, why are you marking alkaptonuria homogeneous oxidase? Homogeneous oxidase, all of us know it is a clear cut answer for alkaptonuria, black urine disease, chronosis, we have heard all those problems, but here nothing has been mentioned. Feet, saliva, urine, fishy odor, fish odor syndrome, laboratory investigation, urine genetic testing confirmed Reye methylaminuriae, diagnosis has been given, they have simply asked that what is the enzyme deficiency, clear cut answer FMO3, flavin containing monooxygenase type 3 is the answer. We have discussed about seafood, sea fish gives us this trimethylamine that should be converted to TMAO, trimethylamine to TMAO is converted by this enzyme FMO3, my goodness, trimethylamine is converted to trimethylamine oxide TMAO by the help of enzyme FMO3, flavin containing monooxygenase type 3. TMA is the guy that is toxic, that is having that fish odor. TMA is the guy that is having fish odor. TMAO is a safer form, that is more water soluble form, easily without any smell. TMAO has got no smell over here beta, no smell in case of TMAO. So in people in whom in their liver this enzyme is, my dear friend, present in the liver, ये liver का enzyme है बेटा, and my dear friend, if this enzyme is present then there is no problem, but if this enzyme is absent then ultimately what will happen beta ji, then the TMA, my dear friends, will be increased and ultimately it will come out through sweat, sometime with urine or saliva, and it will give you the fish odor syndrome. Please remember. Fumaryle acetoacetate hydrolase. Okay, first enzyme deficiency. What is the diagnosis? Hello, जल्दी से करो, थोड़ा जल्दी से आंसर करेंगे. First enzyme deficiency. अरे diagnosis. This deficiency type 1 tyrosinemia. Homogeneous oxidase deficiency, Alkaptonuria. D amino acid oxidase deficiency does not cause any disorder. So 3 enzymes, 3 different disorders that we have to remember over here. But type 1 tyrosinemia. Great. आगे बढ़ते हैं. आज सर तो बाउंसर पे बाउंसर छोड़े, क्या खाके आए भगवान जाने यार, क्या कर रहे हैं सर आज. ये चल क्या रहा है, ओ माय गॉड. Somebody is saying bloom, some people are saying xeroderma pigmentosum, looks like Marfan syndrome वाला बच्चा. Oh my god, ये तो क्या हो गया. Oh my god, ये क्या हो रहा है, ये क्या हो रहा है, ये क्या हो रहा है, क्या क्या देखना पड़ रहा है. Oh my god, my dear friends, please try to understand. Please remember, my dear friends, this answer is going for Bloom syndrome. Oh my god, ये तो bouncer हो गया. B for B, Bloom for bouncer. Oh my god, ये तो bouncer हो गया. आराम से, nothing to panic. Bloom syndrome, कोई बात नहीं. 8-year-old boy enlarged blood vessel in the eyes. मार्क करो ब्लूम सिंड्रोम के फीचर्स को मार्क करो. Please remember, enlarged blood vessel in the eyes, that is usually not seen in case of xeroderma pigmentosum. Dark red color patches over skin on exposure to sunlight, yes, it can be also seen in case of xeroderma pigmentosum. So second line is not so much. Long narrow face, mark karo. Long narrow face, small lower jaw, prominent ears and nose can be seen with multiple things. I will not mark that. High pitched voice. I have just marked those 6 important points that we need to remember for Bloom syndrome. Enlarged blood vessel in the eyes, long narrow face, small lower jaw, high pitched voice. Please remember, these are the important points along with this image, and it is a case of defective DNA repair. It is a case of defective DNA repair. First thing first, try to understand to remove your confusion. Quickly, let us learn this. Left hand side, Bloom syndrome. Right hand side, xeroderma pigmentosum. This you already know. That's why I am focusing on xeroderma pigmentosum first. Please try to understand this. Xeroderma pigmentosum. पहले ये क्या है देखते हैं. In single term, it is nothing but blistering sunburns. Sun exposure होगा, then there will be rashes, patchy rashes. Dry, thin skin, xerosis, freckling, lentigos can be seen before the age of 2. Before the age of 2. Before the age of 2. What is the age? What is the age over here? 8-year-old boy. इतना बाद में मालूम नहीं पड़ेगा ना. ना. अगर xeroderma pigmentosum है, if it is the case of xeroderma pigmentosum, then the cases will be notified much more early. First of all, before the age of 2 xeroderma pigmentosum. Patches of increased decreased skin, and this is called as poikiloderma. Important term. Let us learn xeroderma pigmentosum first. We had something called as poikiloderma. Increased and decreased skin pigmentation. Increased, decrease. Some jagah darker, some areas are lighter. Eye sensitivity to bright light, photophobia is also mentioned over here. This is resembling like also the vampire's disease, photophobia. Eye surface cancers, skin cancer, skin aging. Please highlight cancer. Here the word is photocarcinogenicity. Here the word is photocarcinogenicity. I am writing very important words. Please try to learn it first. In xeroderma pigmentosum, they will definitely mention you that the case later on predisposes to some cancer. आज बच्चे में नहीं है, बाद में होगा. Predisposes to cancer, photocarcinogenicity. And we are also having photophobia. Photocarcinogenicity is the word, right? Please remember this. Coming to Bloom syndrome. First line, most important. Either, hello, either. First line, more important. Only phototoxicity, but never ever photocarcinogenicity. Not photocarcinogenicity. Bloom syndrome is not carcinogenic later on. Please remember. Xeroderma pigmentosum, it is carcinogenic. Very, very important line. Please remember, in the eyes, what do we see? Small cluster of enlarged blood vessel that was mentioned in the MCQ. Either appear in the rashes or in the eyes. Either rashes में नहीं तो eyes. Cluster of enlarged blood vessel. Other signs include patches of skin, light darker. Poikiloderma is a common thing. Poikiloderma, small jaw, large ears, high pitched voice mentioned. Fertility problem, learning problems are also there. And please remember, increased risk of developing cancer at an early age, mainly lymphoma, leukemia or GIT cancer, but not photocarcinogenicity. It is not going to be a skin cancer. Try to understand better. This was the word I told you. Here it is photocarcinogenicity. Due to exposure to sunlight, skin cancers are prominent later on. But here, skin cancers will be never ever seen, not photocarcinogenicity. But yes, can a patient of Bloom syndrome have some other form of cancer? Answer is yes. What are the other forms of cancer? It can be lymphoma, leukemia or some GIT oriented tumors. Some people also presents with gastrinomas, Zollinger-Ellison syndrome, all those things you must have heard about, right? So this is the important point. Please remember, small jaw, large ear, high pitched voice. These two words has been recently given in your MBBS exam, beta. These two words have been given in your exam. Do not miss this, beta. Small jaw, large ears, pointed ears. Sometimes the people call it as pointed ears, high pitched voice. Cluster of enlarged blood vessel in the rashes in the eyes, but not photocarcinogenicity. Now, what is this topic? We have not been studying about these things during the lectures because we did not barge into molecular biology in detail. Remember, in molecular biology, there is a topic called DNA damage and DNA repair. And in our human body, whenever we are sustaining any DNA damage, they are repaired by 6 different ways. What are the 6 different types of DNA repair? Their names I have highlighted over here. 1, 2, 3, 4, 5, 6. Total 6 types of DNA repairs are there. Out of that, please remember, the most common DNA repair that we have in our human body is called as NER, nucleotide excision repair. This is the most common type. Most common type of DNA repair is this. And if we have a defect of this, we have either xeroderma pigmentosum or we have a disorder called as trichothiodystrophy. We cannot learn everything. We have been seeing question on mainly xeroderma pigmentosum and Bloom syndrome. That's why I have focused on that. However, one-liner question also came from something else. That is something called as MMR, mismatch repair. People call it as mismatch repair, but the full word is SDMMR, strand directed mismatch repair. And if we have a defect of this, if this repair is not doing its work, then our DNA, once damaged, it will not be repaired. Then we have a disorder called as Lynch syndrome, which is nothing but HNPCC. What is HNPCC? Hereditary non-polyposis colorectal cancer. It is called as Lynch syndrome. Lynch syndrome also is of two types, Lynch 1, Lynch 2. Base excision repair defect, it is called as MAP. Muti associated polyposis. Muti is the name of the gene, Muti associated polyposis. Then we have got the DSBs. What are the DSBs? Double-stranded break repair. DNA double strand break repair. These are further two types. Homologous recombination, HR, not human resources beta. HR का मतलब हमेशा human resources नहीं होता है. Homologous recombination और NHEJ, that is non-homologous end joining. बाप रे क्या चल के आ रहा है आज? Homologous recombination, and this homologous recombination defect, my dear friends, leads to the MCQ Bloom syndrome, which one of your friends has also understand. Yes, my dear friends, great answer. It is a defect of homologous recombination that comes under double strand break repair defect. DSBs are of two types, HR and NH. This is the defect of NHR. In this one, we also have Werner syndrome, Rothmund-Thompson syndrome, BRCA1, BRCA2 associated with breast cancer, and Neuro-Behçet's disease, Neuro-Behçet syndrome. Non-homologous end joining, if that is defective, we have sensitivity to mainly ionizing radiation, loss of lymphocytes, ataxia telangiectasia mutated. This is important. I am highlighting from where the MCQs might be asked. Ataxia telangiectasia mutated gene, ATM, Bloom syndrome, HNPCC, xeroderma pigmentosum, and the last one, my dear friend, that has been also asked. Fanconi anemia is also due to NHEJ. There is something called as transcription. There is something called as transcription coupled NER. Normally we have studied there is simple term called as NER, nucleotide excision repair defect leads to xeroderma pigmentosum. But there is also a logic that try to understand. Listen to me carefully. What is this transcription coupled NER? All of us know after replication there is transcription. During the replication DNA doubling is done, DNA is made. If a wrong DNA is made or if a damage to the DNA occurs, immediately after replication it has to be corrected by DNA repair mechanisms, which are of 6 types. But what is the 6th type of DNA repair? This is not taking place immediately after replication. Rather, what happens? The faulty DNA, damaged DNA is allowed to start the transcription process, and when the transcription starts or transcription is going on, then the body is correcting its mistakes. मतलब गलती पहले नहीं सुधारा, सुधार के नहीं भेजा, ट्रांसक्रिप्शन करवाते हुए हम लोगों ने इसको रिपेयर को ठीक किया है. दैट्स वाई while the nucleotide excision repair is taking place during the transcription process, not immediately after replication process, during transcription if it is done, then we have transcription coupled NER, and this defect leads to our question also called as Cockayne syndrome. Please remember, there is also something called as beta Cockayne syndrome. Please remember, Cockayne syndrome is a term that we have to remember. Many people give you the answer, Cockayne syndrome is a defect of nucleotide excision repair. No, no, no. Nucleotide excision repair defect is either xeroderma pigmentosum or trichothiodystrophy. But transcription coupled NER defect is called as Cockayne syndrome. Please make a note of this. This is very much important, very, very important. I will be Mr. India if you want to take a quick thing over here. This is very important, beta. 6 types of DNA repair and their defects lead to some dangerous disorder. Please try to make a note of this. Very, very important over here, beta. Cockayne syndrome and progeria are different. Progeria is called as Hutchinson-Gilford progeria syndrome. You must have seen the movie called as Pa by Amitabh Bachchan sir. So that was the progeria syndrome. That is different, beta. But Cockayne syndrome is again a different thing. ओके, आगे बढ़ते हैं. सिंपल चॉकलेट क्वेश्चन, क्विकली आंसर. Read the question, please read the question, please read the question. Finally, you have paid attention to the question. I'm really happy for all of you. Yes, this is what we need on the exam day in the exam hall in front of the computer screen. हमको silly mistake नहीं करना है. I am really happy that none of you have answered the question as A. नहीं तो ये इमेज देखते ही लोगों का नॉर्मल टेंडेंसी होता है that we will mark the answer as A. But no, this is not the answer over here because the question they have asked, lysosomal storage disorder or lipid storage disorder, and most common ALSD causing this is answer as Tay-Sachs disease. Thank you so much. CRAO is the overall most common cause, right? After Tay-Sachs disease, we can remember Gaucher's disease. So if you ask me in this list, overall most common cause में, we should write the answer as A greater than C greater than B. But from the lipid storage disorder, C is the Tay-Sachs disease where it is the most common cause. What is this image? What is this image, Baba? What is this image? Tomato splash appearance, beta. This is best possible answered by the CR view, central retinal vein occlusion. Arterial occlusion में point, here scattered, splashed appearance, right? This you must have heard multiple times in ophthalmology. This is an ophthalmological image, beta, for you to remember CR view. Yes, hexosaminidase enzyme deficiencies. Gaucher's is glucocerebrosidase. and this is Tay Sachs hexosaminidase A, like hexosaminidase Tay, like that we have studied hexosaminidase A deficiency. Sandoff is hexosaminidase A and B. Okay. चेरी रेड स्पॉट वाला क्वेश्चन हो गया. नेक्स्ट क्वेश्चन. I am really happy. Really happy. क्या बात है. Great. 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 Yes, really happy. Really happy. Yes, that means you are looking at the question. Here they have asked enzymes diminished activity. कौन सा enzyme का low activity is responsible for this cataract? And the answer of this question, my dear friends, without any doubt, will be sorbitol dehydrogenase. But if they ask what is the culprit enzyme, this is the culprit enzyme. Aldose reductase is the culprit enzyme for causing the cataract, but sorbitol dehydrogenase low level is responsible for causing the cataract in the lens. Please remember, uncontrolled type 2 diabetes mellitus, glucose, my dear friends, was converted to sorbitol. Sorbitol should have been converted to fructose. Name of this enzyme was aldose reductase. Name of this enzyme was sorbitol dehydrogenase, right? And in the lens, my dear friends, this second enzyme is actually low in lens. This we have studied. This is actually low in lens. That's the reason, my dear friends, whenever you have uncontrolled diabetes mellitus where the glucose level excessively enters into the lens, they are not able to get metabolized easily. Once they are converted to sorbitol, it is very, very difficult to convert it back to the fructose. That's the reason, my dear friends, aldose reductase is making this culprit compound, but this culprit compound could have been handled till fructose if the enzyme would have been present, but this enzyme is low. Culprit enzyme causing the cataract will be aldose reductase. Culprit compound causing the cataract will be sorbitol. And which enzyme deficiency leads to the cataract formation? This is called as sorbitol dehydrogenase. What is the name of this cataract, beta? Snowflake. Yes, already answer has come. Snowflake बोल सकते हैं, snowstorm बोल सकते हैं. Please remember. और starry sky. Sometimes people also use the word as starry sky or snowstorm or snowflake type of cataract. Any of these three names are given in the exam. Okay. Zinc deficiency, my dear friends, without any doubt, rashes around the genitalia. Along with that, they have classically caused the most cardinal sign, diarrhea, 4-month-old child. Answer has to be going for zinc deficiency. No doubt over here. Hope this is. And my dear friends, I have only one guru mantra for all of you at this juncture. You need to focus. You need to focus. Now it is the time. That last couple of days you have, you cannot get distracted, beta. Something going on in your family, something going on in your surroundings, something going on in your personal life. Do not give a damn. Just remember, exam is just couple of days away from us. Only 3 weeks, my dear friends. We will be able to hit the exam. Not even 3 weeks, less than 3 weeks we have exactly. So now is the time that you cannot lose your focus. Follow only one course until you succeed, my dear friends. That is the only guru mantra I have at this point. You have already given your best. and definitely you will do wonders on 17th of January when you are sitting in the exam hall, beta. It will happen, you will achieve it for sure, beta. This question, yes, beta ji, some tricky question. Again, read the question, beta. Many of you have chosen the answer as D. बेटा डी आंसर तभी करना है जब कुछ ना मालूम पड़े. यहां पर मालूम तो पड़ रहा है ना. नाउ यू आर एबल टू गेट द क्वेश्चन. Look at the those of you who has answered it as D, please look for it one more time. Those of you who has answered it as D, please look for the question one more time. Mainstay of first line therapy. Look at the question. Mainstay of now the answers are coming. Now the answers are coming. Now the answers are coming as C. Yes, my dear friends, C is the right answer. What is option number 4? Missing amino acid. Missing amino acid कौन सा होगा? Tyrosine. And we are giving biopterin. So they are asking tyrosine plus biopterin combo. But I told you best treatment modality is to decrease the phenylalanine first. And in doing so, please remember limiting the substrate. What is the substrate over here for the deficient enzyme? Phenylalanine. So that's why, my dear friends, in a case of PKU, we should first restrict the phenylalanine and then we should go for the supplementation. Yes, after you do C, then we have to do D. हमको D करना ही होगा, but C will come first because the question is first line therapy, right? First line में हमें ये देना है पहले. Replacement of the defective enzyme, that means they are talking about enzyme replacement therapy. I told you in the whole world right now, enzyme replacement therapy for phenylketonuria is not yet available. Replacement of the deficient product. Deficient product is what? Tyrosine. That is the same thing. So the part of option number B is similar to part of option number D as well. Missing amino acid or deficient product is same, that is tyrosine. Along with that biopterin, so we can also give the option as B as well. But D is a better answer because they have talked about biopterin over here, right? Hope you are crystal clear with this. One more time, greater than 20 mg per dl is a sure shot diagnosis. And what do you check? How do you check the technique? I told you this is a technique called as beta HPLC. What was the technique name? HPLC, high performance liquid chromatography. HPLC was the name, right beta? HPLC, please remember this. आराम से पढ़ो. भाई ये टफ क्वेश्चन है। हाँ, tandem mass spectrometry will be the gold standard treatment diagnostic method for any IEM if you want to do it immediately after birth. But after 6 months, you can go for HPLC to see more than 20 mg per DL. My dear friends, right answer has not yet come. Sorry. Right answer has not yet come because you guys are not reading the question. Take one more minute, read the question again. जब तक आप नहीं पढ़ोगे हम लोग आगे नहीं बढ़ेंगे. पढ़ो पहले क्वेश्चन को, पढ़ो ना. Why are you rushing? This you know. When you know something and if you miss, then it is a blunder. You have studied this, you know this. आराम से पढ़ो ना, आराम से पढ़ो. Why are you suddenly jumping? Read. Please read. नहीं. Till now only 1%, 2% has given the right answer. Step by step चलते हैं. Step by step. Okay. I will not tell you the answer right now. First you try to understand. You guys are just mugging up sometimes. No, I will not allow you to mug up. You have to understand. 6-year-old boy. Question को पढ़ते हैं. 6-year-old boy. Emergency. Loss of consciousness. Annual day function में बेहोश होकर गिर गया. Oh my God. CBG 46. Very low. Emergency room में shift हुआ. Diagnosis is given ना. Then why are you missing this? Medium chain acyl CoA dehydrogenase deficiency. So what is this case? What is the case? The case is MCAD deficiency, right? क्या पढ़ा है हमने MCAD deficiency के बारे में? What did we learn in the classes? MCAD deficiency, I told you, it is very much common in India. Very much common. Even common than PKU. Why are you missing this? This is the most common from fatty acid metabolism. Most common inborn error in India also. Sometimes is this or congenital hypothyroidism, my dear friends. Very important. MCAD deficiency. What is the medium chain? Medium chain, I told you, 10 to 12 carbon, right? In this case, that is seen in case of breastfeed. This is breastfeed. Now you might be wondering, 6 year, how the hell breastfeed is related? See, here it is not related to breastfeeding. Try to understand. It is not that each and every case of MCAD deficiency will present to you in the neonatal life or in the first year of life. Sometimes it might be a mild enzyme deficiency as well, where the presentation might be delayed. So it is a delayed presentation first of all. It is a delayed presentation that for the first 6 years there was no problem. Hello. Hello. Can you hear me? Hello, can you hear me? Huh? Hello. Can you hear me now? No sound. I did not do anything to the sound. Hello. Now it is coming. Hello. ओके ठीक हो गया. ओके आगे बढ़ते हैं. वन मोर टाइम आई विल गो बैक. फर्स्ट ऑफ ऑल, actually I was shouting at you guys, that's why maybe the god has cut off my voice. See, one more time, start from the beginning. One more time slowly. It's a 6-year-old boy. आराम से बेटा देखते हैं. 6-year-old boy. ठीक है, 6-year-old boy, pediatric emergency, sudden loss of consciousness during the annual day function. CBG करवाया गया. It was 46 mg per dl. It was almost becoming hypoglycemic in the emergency room, and they immediately started on the bolus of D10 dextrose. ठीक है, ओके तो ठीक है. अभी आ रहा है, रुक के आ रहा है, बट आ तो रहा है ना. रुक के देने में मजा आता है, isn't it? Okay, so mother has added that the son also skipped the lunch on that day. That's why the hypoglycemia suddenly kicked in. See, usually, my dear friends, due to hypoglycemia, we can think of many illness. But here it is a case of late onset, delayed presentation of medium chain acyl CoA dehydrogenase deficiency. Now, first of all, take a pause and try to remember, where did we study medium chain acyl CoA dehydrogenase deficiency? This was written to our notes in the form of MCAD deficiency, right? MCAD deficiency. What is MCAD deficiency, beta? MCAD deficiency was the most common type of inborn error of metabolism from the fatty acid metabolism. As well as in India, it is much more commoner even than phenylketonuria. And we also wrote that problem that we have talked about, sudden infant death syndrome, cot death or crib death, you must have heard about. This is that problem. But all of us know, in case of medium chain acyl CoA dehydrogenase deficiency, the vulnerable population is mainly those breastfeeded children. That is mainly the problem starts around 2-3 months, and beyond 1 year the problem can be there. That's why the word is sudden infant death syndrome. Infant means less than 1 year, up to 1 year. But here you are seeing that the patient's age or the child's age has been mentioned as 6 years. How it is possible? Yes, there can be some amount of subclinical MCAD deficiency as well, and suddenly they can be presented later. Because there is a trigger. And what was the trigger? Son did skip the lunch on that day. Usually, if the child is able to be fed on time, I told you many of the time this problem will not be notified as well. मालूम ही नहीं पड़ेगा कि बच्चे में जन्म से कुछ प्रॉब्लम था, because the mother was really taking care of that child. But now the child is going to the school, and during the annual day function he has skipped the lunch on that day. That's why there was an immediate trigger, and he was in the emergency room. Now in this case, it is still a case of medium chain acyl CoA dehydrogenase deficiency. The child luckily did not die, and they have asked which of the following enzymes inhibition explain the sudden hypoglycemia in this child. MCAD, medium chain problem na. So medium chain problem means we have mainly talked about 6 to 12 carbon, and I told you it is either 6, 8, 10 or 12. That means these are all odd number or even number. These are all even number. And whenever you break down any even number chain fatty acid, ultimately the broken down product we all know, it is called as beta acetyl CoA. Even number fatty acid breakdown always releases which guy? Acetyl CoA. And we have studied acetyl CoA, my dear friend, is the allosteric activator of which pathway? Gluconeogenesis. Allosteric activator of which pathway? Gluconeogenesis. Which enzyme? Which enzyme is activated by acetyl CoA for gluconeogenesis? Now I want the answer. I need the answer. मैंने हिंट दे दिया. मीडियम चेन फैटी एसिड, इवन नंबर फैटी एसिड, if you break you will get acetyl CoA. In this child, acetyl CoA formation is going down because the enzyme is missing. So gluconeogenesis will be affected. कौन सा enzyme of gluconeogenesis? Which enzyme of gluconeogenesis, my dear friends? This is this enzyme beta G, pyruvate carboxylase. That is the first enzyme. Very important first enzyme of gluconeogenesis, my dear friends, pyruvate carboxylase. This is one of the 4 irreversible reactions of gluconeogenesis. The first irreversible reaction, gluconeogenesis, starts with this. And I told you, though acetyl CoA himself can never ever get converted to glucose, but without acetyl CoA you can't even start the gluconeogenesis, because it is the allosteric activator of the first enzyme of the gluconeogenesis pathway, that is pyruvate carboxylase. इसके बिना gluconeogenesis start ही नहीं होगा. And that's why when there was a long gap, glycogen should have taken care of. Please remember, but glycogen phosphorylase enzyme is not related to acetyl CoA at all. Pyruvate carboxylase enzyme is related to acetyl CoA. Here you have to join the link with acetyl CoA. Acetyl CoA does not control this glycogen phosphorylase or glucose 6-phosphatase. Yes, there is a connection with pyruvate dehydrogenase complex, but pyruvate dehydrogenase complex has got nothing to do with the explanation of hypoglycemia. For hypoglycemia explanation, either this or this or this, and it is a direct question over here. This is the way sometimes question can be. It is a tough question, it is a bouncer, I agree, but this sort of question has been asked. The history was not exactly similar to this, but they have asked question on the MCAD deficiency, linking it with acetyl CoA deficiency, linking it with pyruvate carboxylase malfunction, linking it with gluconeogenesis, due to which there is hypoglycemia in the child. This is how they have linked the question beta. One more time, MCAD deficiency causes acetyl CoA deficiency, which does not allow pyruvate carboxylase, which does not allow gluconeogenesis to start, hypoglycemia. Last three questions. I hope the voice is coming. Hello. आंसर आंसर आंसर, आई नीड आंसर. हेलो, कहाँ गए रे, क्या कर रहे हो? आंसर आंसर आंसर. ओके, आंसर हैज कम. थैंक यू सो मच. Thank you so much. Alkaptonuria, straightforward question beta. Back pain while teaching for long hours, like me. Oh my god. Okay. Neglected zone of calcification. Physicians, metabolic disorder, biochemistry, Benedict test come positive, because we have studied, my dear friends, today also we have discussed homogentisic acid. Homogentisic acid, my dear friends. Homogentisic acid, that is reducing substance, and in case of alkaptonuria, homogentisic acid will be increased, that will come out with mutra visarjan. It will give you that initial pale straw color, then cola color, then black color of urine, but it will also give you the Benedict test positive over here. What are the other two urine tests which will be positive in alkaptonuria? What are the other two urine tests which will be positive in alkaptonuria? Alkaptonuria diagnosis is never done but by blood test, only by 3 urine tests. 3 मूत्र विसर्जन टेस्ट साथ में प्रॉब्लम होते हैं. What are the other two tests for alkaptonuria diagnosis? Yes, ferric chloride test positive, and third one, color change. Yes, these three things, my dear friends, if it is present together, reducing substance, Benedict test positive, ferric chloride test positive, color change on standing due to oxidation is also positive, answer will go for alkaptonuria, right? Phenylketonuria, you know, tyrosinemia type 2, most common type of tyrosinemia in India due to tyrosine transaminase deficiency, that has been also asked as a question. Argininosuccinic aciduria is a type of urea cycle disorder that we have not touched. We have discussed only 3 out of 6 from the urea cycle disorders. Last two questions. इतना बड़ा बड़ा क्वेश्चन सर, आज क्या खा के आए हो? ओ माय गॉड, क्यों ले रहे हो? Thank you so much. All of you are giving me the right answer. नो 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 नो, क्या कर रहे हो? अरे रे भाई, प्लीज रीड द क्वेश्चन केयरफुली। री बाबा री, ओ माय गॉड, फ्यू ऑफ यू हैव गिवन द राइट आंसर। यार बायोकेम में एक चीज तो हमें समझ में आ गया, आंसर इज डी। आंसर इज डी। प्लीज रिमेंबर वन मोर टाइम माय डियर फ्रेंड्स, लेथार्जी, वीकनेस, शॉर्टनेस ऑफ ब्रेथ, ओके ठीक है, इनफाक्ट, ओल्ड इनफाक्ट, एंटीरियर वॉल ठीक है, नेवर बीन हॉस्पिटल, अनरिमार्केबल रिपीट प्रोफाइल, हाई होमोसिस्टीन लेवल, मिथाइल मैलोनाइल कोए ऑल्सो एलिवेटेड। दिस इज ए क्लियर कट। इससे ज्यादा इजी क्वेश्चन क्या होगा? मिथाइल मैलोनिक एसिडेमिया और एसिड्यूरिया, MMA is positive. Answer will go for B12 deficiency. This is a clear cut for B12 deficiency. In this topic only we have discussed about subacute combined degeneration in our notes. Please try to read that page from the lipid metabolism. That is very much important, beta. MMA elevated, beta. Methyl malonyl CoA, it is the vitamin that is required for the L-methyl malonyl CoA to succinyl CoA conversion, right? So we have been discussing about that. That's why methyl malonyl CoA will be elevated. What type of methyl malonyl CoA? The full form of that guy is called as L-methyl malonyl CoA. This was supposed to get converted back to succinyl CoA, but this is not going to do that. D. बोला था ना डी आएगा, देखा डी। भाई इधर डी हो रहा है, एग्जाम में थोड़ा देख लेना। अच्छा, पायरिडॉक्सिन क्यों आंसर कर रहे थे? टेल मी तो, व्हाई द हेल यू गाइस आर आंसरिंग इट एज पायरिडॉक्सिन? पायरिडॉक्सिन के साथ होमोसिस्टिनीमिया, ऑल ऑफ यू नो, सी लेट मी आल्सो हेल्प दोस अदर स्टूडेंट्स एज वेल। होमोसिस्टिन लेवल कैन बी सीन विथ B12 deficiency, B9 deficiency, B6 deficiency as well. But in B6 deficiency, my dear friends, MMA no connection. B9 deficiency MMA will be normal. B6 deficiency में तो कोई MMA का connection ही नहीं है ना. So this methyl malonyl CoA, what they have given the extra hint, now with that only we have to go for the diagnosis as B12 deficiency, right? Last question of the day. Last question of the day. Last question beta, let us wrap it up. लास्ट क्वेश्चन का आंसर मेरे को सही चाहिए, सही चाहिए, नो सही चाहिए। आई वांट द राइट आंसर। yes, all of you are thinking in the right line beta. It is primary familial hypercholesterolemia. This is nothing but the type 1 hyperlipoproteinemia. From that, Frederickson Levy-Lees classification, FFL classification that we have studied in the lipoprotein chapter, it is a question of that beta. Middle-aged male presented to OPD, सीरम ट्राइग्लिसराइड 140, ओके। टीजी नॉर्मल लेवल कितना है? ओके, हेलो, ट्राइग्लिसराइड नॉर्मल लेवल इज अप टू 150 mg/dl. टोटल कोलेस्टेरॉल इज एलिवेटेड, टोटल कोलेस्टेरॉल नॉर्मल लेवल अप टू 200. LDL नॉर्मल लेवल up to 100 mg/dl. HDL normal level, we wrote it in the book. In case of females it is 45 to 60, in case of male it is 35 to 50 mg/dl. VLDL depends on the triglyceride level, because triglyceride by 5 value is actually VLDL. Please remember, TG level by 5 is equal to VLDL. TG level by 5, ट्राइग्लिसराइड का जो वैल्यू होता है ना बेटा, उसको अगर 5 से डिवाइड करते हो, दिस गोज फॉर द VLDL. इफ यू जस्ट सी 140 डिवाइडेड बाय 5 इज हाउ मच? 140 divided by 5 is how much? 28. So this is the exact formula, beta. Tg by 5 is VLDL. So in this patient which is elevated tremendously, LDL is high, HDL more or less okay hai, VLDL varies with the triglyceride. So LDL is only elevated over here, and he also complains that his elder brother also faced similar scenario at this age and died within a year time. So it is lethal type of disorder and it is running in the family. What is the inheritance pattern, beta? Autosomal dominant, and it is the most fatal, and it is also the most common type. Most fatal and the most common type as well is the primary familial hypercholesterolemia. This is the type 2A, beta. This is type 2A, most common. Just a moment. This is the type 2A hyperlipoproteinemia. Type 2A, this is the autosomal dominant one. Type 2 is under two type 2A and 2B. 2B is not our topic, beta. Type 2A is the most common type, it is the most fatal type, and it is running in the families. So primary familial was. Familial combined hyperlipidemia is a different thing. Please remember the word combined hyperlipidemia. Due to the word combined, we have to also remember in case of familial combined hyperlipidemia, there will be also rise of the VLDL as well. LDL भी rise होगा, साथ में VLDL भी rise होगा, and the IDL also will rise. That is a different disorder. But here the VLDL is within normal range because you are seeing triglyceride is normal up to 150. Here it is 140. So VLDL is Tg by 5. That is also within the normal range. But here our diagnosis is better. The most common type, primary familial hypercholesterolemia. We have also been discussing about those few images which has been asked. If you remember, corneal arcus, xanthelasma, atherosclerotic plaque in aorta, some tendon xanthomas over the knuckles as well as over tendo Achilles, TAT xanthoma, TAT xanthoma. So all those that we have discussed are also essential for this question, beta. In the last FMGE exam, they have asked question on type 1, that is called as chylomicron syndrome, where triglyceride will be high and patients will present with eruptive type of xanthoma. But this is type 2A, primary familial hypercholesterolemia. That is the most common type as well as the most fatal type, and autosomal dominant, runs in families. They will give you some positive histories. Their father or their elder brother died due to the similar type of disorders. So my dear friends, okay, yes, A beta lipoproteinemia, and my dear friends, A beta lipoproteinemia is the absence, A for absence of the B number containing apoproteins. B apoprotein contain lipoprotein. Like we have got two types. One is B48, another one is called as B100. B100 is a part of VLDL, IDL, LDL. All three will be low. B48 is a part of chylomicron, so that also will be low. B48 becoming low, chylomicron synthesis will go down, so you will not be able to absorb the fats from the intestine. That's why in these patients the most common sign will be the malabsorption of fats, due to which the cardinal sign will be steatorrhea, and the patients can also present with acanthocytes in their peripheral blood smear. You will be seeing RBCs are having some spine-like projections. Those are called as beta acanthocytes. Acanthocytes. What is Tangiers disease? Tangiers disease, my dear friends, please remember better. In Tangiers disease, basically we have problem with the HDL level. High density lipoprotein, or HDL, my dear friends, will be very low. It will almost become close to nil. I told you HDL level in case of males should be between 45 to, in case of females it should be between 45 to 60. In case of male it should be between 35 to 50. But in the patients of Tangiers disease, that is called as hypo-alpha lipoproteinemia, what will happen, beta G? The HDL level will be almost close to only 5 mg per dl. And HDL, if it is so low, obviously LDL will take the upper hand and it will become high. And now there will be massive cholesterol deposition in different body parts, and it starts from deposition from the tonsils are deposited with LDL, which is called as orange yellow tonsils. Last two images of the lipoprotein chapter is A beta lipoproteinemia and the Tangiers disease. Tangiers disease, why the name? Because there is an island in Morocco, Tangiers Island. This disease was first noted in that country. That's why people call it as Tangiers disease. But it is mainly the alpha lipoproteinemia beta. Alpha lipoprotein is also the HDL that is becoming defective. Please try to remember beta. A beta lipoproteinemia and Tangiers disease, these are all due to some gene mutation. Tangiers disease is due to ABCA1 gene mutation, ATP binding cassette transporter type 1. ABCA1 type of gene mutation is this Tangiers disease. And A beta lipoproteinemia is MTTP gene mutation, MTTP, microsomal triglyceride transfer protein gene mutation. A beta lipoproteinemia is MTTP gene mutation. Tangiers disease, it is ATP binding cassette, ABCA1, ATP binding cassette transporter A1 gene mutation. One is ABCA1, another one is MTTP gene mutation. These are the two gene mutation that causes the two disorders which comes under hypolipoproteinemia. Thank you so much for giving me the opportunity to teach you guys beta G. It has been almost more than 3 hours since we have been discussing today. I hope we have been able to learn something new. Some mistakes that we have committed, we will not repeat the same thing on the exam day. So please make a note of this as beta. And what to say, really praying for you always beta. And I hope that all of you do your best, and rest you leave it to the God, and God will do the rest, my dear friends. Whatever has happened has happened. Think about where you are going and never mind from where you are coming, where you have been. Those days are gone. Now you are only one step away from converting yourself from a foreign medical graduate to become an IMG very soon once you pass the licensing exam. And I hope all of you, each and every one of you, sincere from the bottom of my essay node, I am praying for all of you that you come out with flying colors once the results are out beta. Thank you so much. And due to my voice, probably I was a little bit with the full josh, but I hope that all of you have been able to grasp that we have been discussing. Thank you so much beta. God bless you. Take the blessings of your parents, take the blessings of your seniors, go to the exam, pray for God, and God will do the rest. God will give the power to mark all the answers correct, necessary amount of answers correct to pass the exam. May each and every one of you pass. Thank you so much. Thank you to the Almighty, and believe in yourself. Thank you so much beta. Good night.